pleasure in our live stream.
Hoi da pawb, croeso cynnes iawn i chi gyd. Good morning everybody and a very warm welcome to you all. So a few welcomes to this one, if you don't mind. First of all, we've got our graduate management trainees with us today. We've got Katie, Bev, Nia and Daniel. Well, welcome to you, nice to see you. Most of the opportunity, please. We've also got, for the first time, Dina Patel. Hi, Dina. Dina is aspiring board member and the program that we support through Welsh Government. It's lovely to have you with us, Dina. And I hope you form a positive opinion of the board, and hopefully in the future you might decide to seek a post within one of the board's managers. So enjoy the day today. Any questions you've got, can see. Okay. We've also got with us an older head altogether, Clive. We all know Clive, he's covering for Emma today, but this is you, Clive, and a warm welcome to you as well. Apologies for absence. I've got Emma Cook and Rashna Apyar. They can't make it today. Any other apologies, Matt? Anybody else? Go online. Okay, thank you. Has anybody got any declarations of interest, please, on items on the agenda today?
Yes.
So, right, duly noted. Thank you. Right, next item is minutes of the board meeting. We've got two to run through, a normal one from 29th of May and a special board meeting we held on the 25th of June. So I'll deal with the May meeting first of all. I'll go through the minutes page by page. If colleagues have any adjustments they want to make, please raise them as I go through. And if there are any matters arising which do not appear on today's agenda, flag them at the same time. Okay, so page 1, 2, 3, 4, 5, 6, 7, 8.
Chair, page 8. I don't know if it's it. 2505.6.9, but right down at the top of page 8. I think the comment that I'm not sure the comment connects to the issue that's read by the independent member, because I can't imagine that we'd be suggesting JCC get involved in the commissioning work around primary care access. So just not sure that connects.
Okay, can we review that minute, please? Yeah, thank you for that. Any more on page 8? Page 9, 10, 11.
Well, on 11, Chair. So there's a random number 11, which I assume was a page number that's been put into the text. So it's under the section on tobacco, second bullet point. It just ends with the number 11.
It's got. We'll take that out. Thank you, Claire. Page 12, 13, 14, 15, 16, 17, 18, 19, and page 20. Apart from the identified corrections, are we all content that's a true and accurate record of the meeting in May? Thank you very much indeed. We move on to the minutes of the special board meeting held in June. I'll do the same procedure. I'll go through page by page. If you've got any alterations to shout out. So any matters arising not appear on today's agenda, flag. So page 1, page 2, page 3, and page 4. Are we all content with a true and accurate record of the special board meeting, Jim? Thank you very much indeed. Okay, the actions following the meeting on the 29th of May. The action log you have in front of you, Matt?
Yeah, they're all marked complete. The ones for board are on the 4 plans, and then the others by the reporting committees or from committees to us again are either being covered today. Each meeting.
Thank you, Matt. Anybody got any questions surveyed on the action log? Happy to note. Thank you very much. Okay, the next item, 6.1 on the agenda, under review and assurance, it's the patient's story. Jason, can I hand over to you for this one?
Yes, thanks, Chair. So I'm obviously going to present Keith's story. I won't say too much about it yet, but
this story was based on the fact that our resuscitation team did a specific piece of work through our Strength and Scale Academy, reviewing cardiac arrests in hospital. Obviously, what we call the chain of events, to make sure that every bit of the chain works for to increase and improve survival. So slightly different. So you'll hear that Keith wasn't a patient. He was bringing his wife into an outpatient department when he had a cardiac arrest. And, you know, I'm sure we hear the story between myself and our own resident cardiologist. We'll answer any questions. But, you know, to have a cardiac arrest in an outpatient department is almost like having a cardiac arrest out of hospital, because cardiac arrests very rarely happen in an outpatient department, if ever. So, you know, the staff were admirable in how they managed to do that. And you hear that, you know, the nursing staff had been on a plant site support 2 weeks ago, so it all sort of fitted well for Keith. So we'll get to see the story, and I'll have to take it. Thank you. I think for the first 20 seconds it's silent and quiet.
My name is Keith and I survived cardiac arrest at the University Hospital of Wales. I said to Lynn, I'll drop you off at the women's unit for her first appointment. So I was the usual thing, trying to park. And I walked from Glamorgan House to the women's unit and then sat down in the corridor with Lynn and we had a chat. We were just waiting. Lynn will give you the rest because I know nothing about it.
Yes, well, I was in the waiting room and I saw Keith coming in. He sat down for a moment. We were chatting perfectly normally. And then they called us to wait in the corridor. So we sat down in the corridor and then just suddenly he keeled over and his lips were turning dark, black. So I called the nurses and they came running and the consultant came running. They put him on the floor and started CPR. And obviously called for the crash team. And I was leaning over him, talking to him, Keith, Keith, Keith. And I was tapping him on the head like I didn't know what to do because I didn't want to get involved. So I was tapping him on the head, Keith, 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 like this. No response. And then the crash team came. And with that, then the nurses took me away into a little room. But I could hear everything that was going on. But they were so kind. She tried to distract me talking about lots of different things. She stayed with me, and then once he was stabilised, they took him down to A&E. And they said that once they sorted him out, they would send for me. So I stayed with the nurse then, and she chatted to me, looked after me. She was absolutely wonderful. Then I had a message, you can come down to A&E. Not knowing what to expect, but when I got there, Keith was sitting up in bed, beaming all over his face, and he said, "That's ironic, I was bringing you for your appointment." But then I waited till he was then taken onto the ward, and you were sitting eating. This was like 10 o'clock at night. He was sitting, they got something from the kitchen for him.
Yeah.
Everyone was absolutely brilliant in the hospital. I can't praise them enough. We were so lucky that it happened there, because we were even luckier then because they kept him in and decided straight away when they looked at him in the angiogram to do a stent.
Yeah, I was listening to the team and the consultant said, I can see what it is. There's some restricted arteries, so I'm going to put the first stent in, he said. So I'm like that, and I was shouting out, "Thank you, team, thank you very much for that," you know. And then he said, "Right, we'll have you back on the Wednesday and we'll put the second stent in. Again, thank you very much." And then the other consultant came in to see me in the ward and he said, "We've decided on Thursday, the next day, to put in a pacemaker and you can have a day release in about 3 weeks' time to get the third stent in." Again, I couldn't thank them enough, the whole team, you know. That's just fantastic.
So 42's call had gone out to gynae outpatients. When we arrived there, we found, much to our surprise, that it was a gentleman lying on the floor with the nurses there doing CPR. They'd already shocked him before we got there. We carried on with the resuscitation, did some more basic life support. We had another couple of shocks. We got return of spontaneous circulation, and he was transferred to EU, where I believe he then went to be stented and made a full recovery. This was in an area where obviously they don't see cardiac arrests, not even very often, but not at all. But the nurses, luckily, who were on duty on the day, a couple of them had done their ILS courses just a few weeks before. One of them had said, you know, I had this training a couple of weeks ago. I didn't think I was ever going to need it. And so it was just really nice that they'd obviously picked up quite a lot from, you know, from their training and put that into practice when it was needed. So them starting basic life support and getting a defib on.
So a hugely positive story, as you can get from kids. The way he describes it, he's elated and he's been given a second chance, I suppose, at life. And so this was about, they just wanted to prove that child survival, which the Resuscitation Council talks about, based on two things: time critical. So for each minute that CPR or defib isn't used, your chance of survival reduces 5 to 10%, 7 to 10%, and teamwork and training, which means every person along the way needs to know exactly their part in the rest in order to improve survival. So, I mean, I don't know, out of hospital survival rates are really, really low. David, I'm going to hand over to David because David is the expert. But
That local survival rates aren't very low because they don't do the basic stuff early. There are places where they have established community expertise in basic life support. Survival rates go up quite massively. In fact, I mean, Suzanne called my attention to the obituary on Channel 4 on Radio 4 recently. That's Douglas England, who actually was an advocate 30 years ago of upskilling the community response in these situations. And he actually had an honorary professorship, which I didn't know, at South Wales at University of Liverpool. So he started it, and actually, we were talking, weren't we, about the availability of defibrillators in the community, and actually that's one of the things that I'm in the story. I need to find out about what is the community capability doing, because as you can see, it makes such a dramatic difference to not only surviving, but surviving completely intact from where it was before. So it's fantastic.
Yeah, David and I was doing something this morning about the fact that with a house provider, Woodland House, health provider, and I'm not aware that we've got a defibrillator. We have?
Yeah.
Oh, there we are. See, so I didn't know, so I need to make myself aware of where the defibrillator is on site. Yeah.
Thank you. Steve.
The Dave's right, Wales has got one of the lowest out of hospital survival rates for cardiac arrest. Some students at Cardiff University, I think, incorporating Cardiff Met and the University of South Wales, have been running for the last 5 years a Student Saved Life campaign. So we've been in at Tesco's at Gavalfa and in St David's and at Tesco then from Walker, I think, and they train members of the public. So we grab them as they come through the door. Students put them through the paces on the floor and with the dummies, and we can't remember the exact figures, but it's thousands of people that have been trained. We're trying to roll it out across Wales through Saving Life Cymru, and we've got a grant to do some of that work, but it is quite hard work because it's a lot of involvement trying to get the students out to places. But so things are happening, but it is a challenging area.
In Denmark, what they did is they went to the schools, because clearly the children are the people, you know, who are more likely to have a heart attack. So actually, if you train younger people, that is good.
The one thing I was going to link is a fantastic story, and I can only imagine just how the team would have felt to find that gentleman in that situation in their department, because it would be so unfamiliar and terrifying for everybody, including obviously patient's wife. It's really frightening. So the fact that they were able to mobilise an effective response despite what would have been a very anxious scenario is really impressive, and speaks to the value of the training that we talked about today. So thank you for sharing that with us. I was just reflecting on the conversations we've had about Cardiff and Vale and UHB being the cardiac arrest centre, and the effective commissioning or not of that. So just to make all colleagues aware, we are operating a cardiac arrest centre. Trying to unpick what that exactly means, I think, is quite tricky, but I think it means that patients who experience out of hospital arrest and whose circulation has been established are brought to us, maybe over and above going to another health facility because of the other services we have that may well be able to support them in their recovery from what will obviously be a very potentially very challenging scenario. But it transpires as we find that we aren't actually commissioned to deliver that service in a formal and effective way, and so we are just working through that at the moment. But again, I think we had a JCC conversation last time we were here. The team came to talk to us today about their approach and the prioritisation. This will be another thing that we'll need to navigate with them, because I think that the clinicians feel they're delivering an effective service, but there will be no clear lines of funding or specification. Likely that we will cover some of the funds through existing LTAs, as we know. But it is just, make you aware that we do this. It's on the horizon, and it is something that we have been in correspondence with our JCC colleagues about how are they going to take it forward. And because ideally we wouldn't be the only centre in Wales, to the point that Steve raises about the general recovery. So just not directly connected, but part of the story in a way.
Okay, thank you, Jason, for the story. Very happy ending to an unfortunate situation which couldn't have happened perhaps in a better spot for the individual concerned. And I'm quite curious about his wife tapping on the head all the time. I'm not sure whether that's part of the process. It's very enlightening story, and it speaks volumes to the work of our staff. Yeah. How responsive they are and how effective they are. Thanks for sharing that with the board. Please pass on our thanks to Keith for sharing that story. Okay, next item is my chair's report. I'll take the report as read, but I do want to draw your attention to a few items. Okay. First of all, as you know, my term of office as chair finishes at the end of September. I'm delighted to announce the appointment of Kirsty Williams, who will become chair of Cardiff and Vale University Health Board with effect from the 1st of October. Many of you will know Kirsty's track record to some degree, both in public life and as vice chair of Powers Health Board. I think she'd be an excellent chair of Cardiff and Vale University Health Board. I think she's already got an excellent team in place to help her and yourselves take the organisation forward. So congratulations to Kirsty. The next young lady who I need to congratulate is our own Sarah Mosley. Sarah has been appointed, as we all know now, to the chair position at Belinda Trust and commences her duties with effect from the 1st of September. It's a wonderful recognition of your ability and skills, Sarah, I think, but we need to recognise the work you've done here in Cardiff and Vale during 8 years in office. So a fantastic contribution from you here. So thank you on behalf of myself and the board for that, and congratulations on your appointment. This is actually Sarah's last meeting with Cardiff and Vale in public. We'll have a chance to say a bit more in August in our development session, but thank you, Sarah, for this contribution. And this is the first public meeting of the board where we've been joined by Clive Curtis. Clive is a new independent member It's a general role, but focusing on community. Clive has a wealth of experience in the community. Lovely to see you with us, Clive, and welcome on board. I'm sure you'll add significant value to the work of the board. Looking forward to working with you. Another welcome, I did mention earlier on Vina Patel, but can I do that again? Very warm welcome, Vina. It's nice to have you with us as an aspiring member of the board in the NHS in Wales. And we will give you as much support as we can, or indeed that you need, to help you determine which way you want to go in the future. But we're here to help and support. Welcome on board. Perhaps I could rather sadly turn to a very tragic recent piece of news we all received, and that's the loss of our former executive nurse director, Ruth Walker, who very sadly passed away on the 16th of July. Those of us who work with Ruth will know her as a monumental force for good within the organisation, a real powerhouse in terms of energy and effort for clinical work, widely respected across not just Cardiff and Vale, but the whole of Wales NHS, and in fact nationally. So it's a very sad loss for Ruth, who was far too young not to be with us anymore. And we wish to pass our condolences on to her family and friends. It's a very tragic time. For those of you who are able to go, the funeral is on Monday, and it's in Ipswich. I can give you the tidbits on it. So very sad. I'll move on to the spotlight story for this month, which features the Armed Forces Week and the work of the Armed Forces. And I apologise to my colleague David Edwards because I omitted to mention him in my report, which is really a problem because David is our champion for armed services on the board. And he actually attended the launch of Armed Services Week and actually did a speech with the Minister for Mental Health. Sarah Murphy is in attendance. And David has done a lot of work. He's been very active in promoting the armed services and how the board is actually. So thank you for that, David. My personal apologies. We will correct the report on the public website after this meeting. Also, my thanks to Matt Phillips and to Maisie Proven, who also do a lot of work ongoing with the armed forces. We have a very good relationship with the armed forces and how we work together. So my thanks to all three of you for the work you do. The last item is just to draw to your attention that within the report you'll see the usual advice of applications of the Common Seal and legal documents that needed to be signed. So I'll finish my comments there. Does anyone have any questions they want to pose at this stage?
Not a question, Chair, but thank you for including photographs of the naval officers, cadets. I've never seen pictures of the Royal Navy in a Chair's report before, so it's achieved me up enormously when I saw it. So thank you.
You were wonderful on the day, actually. That's marvelous.
It's very smart.
They did. Had a bit of trouble with the flag, but it was sorted quite quickly.
That happens.
Yeah. Okay, so if there are no further questions, are we happy to note the report and approve the chair's actions undertaken and approve the application health board seal and completion of the agreements detailed within the report? Thank you very much indeed. I'll move us on then, if I may, to 6.3 on the agenda, which is the Chief Executive's report. Suzanne.
Thank you, Chair. So the report covers quite a lot of different aspects in some detail, but I'll just draw on a few key themes. You'll have noticed the report is themed around celebration, success, and reflecting on where our colleagues deliver amazing care or are leading great innovation and adaptation of our systems and processes. And I've chosen to do that in quite a purposeful way. And that is because I wanted to balance some of the more challenging news that we've had recently. And I articulate in the very front of the report a reflection on the fact that the health board's escalation status of targeted intervention has now been broadened as of the 15th of July to include, as we understand it, all elements of the organisation's delivery and focus, which is clearly very disappointing. But I wouldn't want. I'm not undermining that position. I recognise it. We've clearly failed to deliver on a number of important areas, including the delivery of our financial plan, some of the trajectories that were set for planned care and diagnostics, despite significant improvements being made and vast volumes of activity being delivered, didn't meet the requirement. And of course, more recently, we've had a very challenging comprehensive service review into our operating departments at the University of Wales. So it's perfectly reasonable and understandable and legitimate that those aspects have created concern and a feeling that there needs to be greater emphasis, more pace of improvement and more scrutiny, all of which discussed, Chair, and I'm sure we will in the board as the board progresses today, that I certainly recognise those challenges, and I'm very confident that my colleagues and I recognise it and will work incredibly hard to recover that position. It didn't really give a balanced perspective on the work of the health board, and I'm very aware of the impact of such a position on the team effectiveness and morale. And we see that probably most significantly in the leadership team, beyond the team in this room. A feeling that it's difficult to be able to demonstrate both sides of the position, and that can have a very negative effect on colleagues' motivation and commitment and support. And so I felt it was important to take this opportunity to bring some balance to some of that. But in no way being lacking any humility about the position that we find ourselves in. There's also really good evidence, which you'll all be familiar with, and I referred to in the report, that demonstrating balance, effective, compassionate leadership, and creating a cultural approach within the organisation that enables that balance is really important, and supports the delivery of our objectives, which is to deliver fantastic quality care, for colleagues to feel valued and supported in the doing of that, the organisation to have an open and transparent culture. So it's not just a soft piece, there's actual empirical evidence that supports that, and it's an important task for the board and the leadership here to apply ourselves to, and we need to apply ourselves to it with the same rigour that we will bring to scrutiny of challenges, focus and delivery in that way. So that's the context and the tone of the report, and I've picked out in each of the strategic objectives something that gives example to that. Would also like to just recognise that this month the NHS is 77 years old, and despite the very many challenges which are well documented and discussed at great length, in the media, in the system, and in institutions and organisations across the UK, it does remain a very important part of the United Kingdom's culture, our approach to life, what is important to us as people, and of course in Wales, a very special link since the NHS was founded here in Wales by Nain Bevan. I think it is important to reflect that that continues to be a very treasured institution, despite the fact that we have feedback, which you can understand from population. Sometimes it's not good enough, it's not fast enough, it's not technical and digital enough. We recognise those things, but it's still something that's very close to our population's heart, and they care about it, and we have to understand and recognise and appreciate that. We had a number of colleagues identified and acknowledged within the most recent King's Honours, Birthdays Honours, and I've named everybody that was that has been awarded. But just to recognise our very own Professor Mary Jenny, who has been awarded a CBE no less for her work here in the Health Board and with children cancer treatment and research across the world. So huge congratulations to Mariel and everybody that was named in the honours. And we don't make those nominations. Those nominations are made by colleagues for colleagues, and that's really wonderful to see. And we encourage everybody to make nominations in that way, so that our colleagues can receive the appreciation and very great honour that it is, as they deserve. Volunteers Week, important to focus on our volunteers. Without them, we would really struggle to deliver some of the quality of care that we hear about in patients' stories, such as the one we heard this morning. I'm sure there'd have been a volunteer in there somewhere providing support and assistance. And we had an event here in Woodlands House. It was absolutely inspirational. I can't really put a better word on it. To hear the stories of our volunteers, to hear them talk about their passion and their commitment to both the patients, the communities they're serving, to our teams and to the organisation. It was really, truly inspirational. So I really wanted to salute them and thank them for their huge support, which of course is given freely out of their own time. And, you know, often they're delivering a huge level of commitment, which is really, really worth celebrating. I think it's fantastic to see the leadership listening walk-arounds being deployed. The board will know that we've done that work in a co-productive way with yourselves and others. And this ties really well with the work that we need to do in the organisation, which is, you know, have the spotlight placed on it by the Theatres Review in terms of culture, leadership, and the leadership listening walkabouts. I think are going to be fantastic. I know they're in the diary. I'm looking forward to getting on. Some of them might even have started. First one tomorrow. So, but I wanted to just say thank you to all of you for contributing to that work and that refreshed model. And as you can see, it's a more systematic approach, which includes our involvement, clinical board leaders leading and spending time with their teams and leading in action, self-assessment process and a process of peer review across the organisation, which I think will really strengthen our quality governance and understanding, as well as our engagement in the really important leadership of our organisation. So thank you to everybody that's contributed to that. Great step forward in terms of delivering digital healthcare. So electronic prescribing and medicines administration has begun its rollout. This is a really important part of our future electronic healthcare record and will enable us to improve and strengthen our safety in delivery and prescribing of medicines. So huge thanks to the team. It's been an enormous amount of work, and I know Jason and his team have been really really instrumental in getting rollout delivered alongside Dr. Mark Wardle, who is our CCIO, our chief
information officer.
And Mark and his colleagues came to our Suzanne session, I think it was the last one actually, and did a detailed briefing to the organisation. What is this? What's it going to do for you in your area of practice? If you're interested, how to get involved. By the way, you need to be interested because it's coming to you. It's coming everywhere, and it's a really big session. So yeah, a really important milestone for us. I think David, you'd agree as well, wouldn't you? That this is really key to our delivery of digital healthcare into the future. Partnership working. I've covered off a few elements of partnership working in the report, and partnership working. I think we talk about a lot being important to the successful delivery. But partnerships require time, investment, shared understanding, and I hope I've given in the report some examples of where we're taking time, despite all the many challenges, to do exactly that. Spend time with our colleagues in their partner organisations, or time with colleagues, developing and strengthening our relationships. And we're going to continue to need to do more of that, so that we are spending that kind of really important quality time with all of our partnerships. But as you can see in the discussion around the Partnership Asset Management Board, which, you know, Catherine has been absolutely instrumental in driving the increasing effectiveness of, actually this is an important part to organisational sustainability, a one public estate agenda which rationalises and ensures that we are taking all those shared opportunities is really important. And Catherine, I know, will speak more in more meeting later around space rationalisation work that she's been doing with the team in the organisation. But I think all of that work, Catherine, is involved partnership discussions and support. And then last but not least, in terms of the kind of focus on the different areas of our strategy, I feel I should speak to the solar panel installation at the Univet institution. It feels like we're a solar panel institution at the University Hospital of Wales. multi-storey car park. So this programme is part of our strategic programme, refit programme, and clearly is part of our commitment to the government's decarbonisation strategy. But as you will imagine, it is creating a lot of distress even in the organisation, because we've had to close the top 2 layers of the car park. We've already done this work at UHL quite successfully. We've chosen this time of year to do this really important piece of work, which we do have to do, because July, August is going to be the least worst time. But, you know, clearly we're still hearing from colleagues the difficulties it's giving them in terms of being able to park their vehicles, get to work on time, and all of the rest of it. So I wanted to just make the point that this is important work. It will reduce the costs in our organisation. It will contribute to the decarbonisation agenda, which we have to contribute to. It's part of the requirements placed on us by Welsh Government. But we also know and understand that it's creating challenge in the organisation. It's a really complicated piece of work that will run until October. So we've heard the feedback, and a number of mitigations, additional mitigations have been put in place. We're looking for additional car parking, and some of that's already been secured. We've I've sent communications out to the organisation about, you know, how to access a bit more latitude around the tickets that might come, and just for everyone to be patient with each other and understand this is important work. There's no great time to do this. This is, say, the least worst time. And please, you know, we're trying to promote things like the park and ride, active travel, and if you need more assistance with that, then we're very happy to connect colleagues up. But again, that section speaks to a whole ream of work that's going on around the sustainability agenda. And my Ask Suzanne on Friday is a climate emergency special. So if you're interested in what we're doing across all aspects of addressing the climate emergency, we've got, I think, 4 different clinical teams from 4 different parts of the organisation coming to tell colleagues about the work they're doing, and it is brilliant work that they've been awarded for at a national level, and which has been published and been leading the way very often in that regard. So so that concludes the kind of focus on the good, and you know, clearly I've identified 2 important aspects for the board to have escalated here in a formal way. Clearly the in-year financial position continues to be challenging. There have been a number of meetings and correspondence with both the Cabinet Secretary and the Director General and Chief Executive of NHS Wales, where they're looking for us to give, as we have done, assurance on our current forecast delivery of £56.2 million. And we have given that assurance, and Catherine will give more detail around that as we get to the reports later. But, you know, that in itself will be a challenge, but we have committed to it because we believe it is possible. But we're also being asked, as you will know, to go better than that. And we have been looking at the opportunities to do that, which are not many at this point in the year, if I'm honest. Really, we have to reduce our overheads in order to achieve that, and we'll reduce our expenditure rates, all of which will be a challenge. But we are applying ourselves to it, and there'll be a more detailed discussion later in this meeting. And clearly, I refer to the escalation expansion. We await the de-escalation criteria and framework from our Welsh Government colleagues, and as soon as that is, we're already doing the work necessary, really, but it'll be helpful to understand what the detailed requirements and criteria are, so we can make sure that our actions are appropriately.
Thank you very much, Suzanne. Any questions for Suzanne? Can I just add to Suzanne's comment? I mean, Suzanne has covered the escalation situation admirably, I think. You particularly did it very well, Suzanne. But there's a temptation sometimes when this adverse news reaching the organisation, particularly the expansion of the escalation status across all domains that are now form part of that programme. It's a temptation for heads to go down. Okay? There is no need for any heads to go down in Cardiff and Vale. This organisation is excellent in what it tries to deliver. What we're looking at here is Welsh Government trying to channel some extra support into the organisation to restore those areas where perhaps our performance hasn't been as strong as we would like. So look at it, please, with a positive slant, not a negative slant. Encourage your teams to do the same, because this is an unfortunate step. You can escalate it twice in the same calendar year effectively, and that's a bit unfortunate to say the least. That's why I'm concerned about morale and the impact it could potentially have. We are great leaders in this organisation. Around this table, I've got some amazing leaders. Okay? So spread the positive influence of this escalation status for us to maximise the support that will be coming our way. It might feel like more scrutiny, and it will be more scrutiny. But the intention is for the NHS in Wales, Cardiff and Vale in particular, to improve the contribution that we put forward. So look at it, please, through a positive lens, not a negative lens. Something that we should strive to de-escalate from, and we will do that. I'm confident in that issue forward. But you need to understand this is a step to help us, not a step to hinder us. Okay. Thank you. Sorry. Any further questions? Thank you, Suzanne. We'll move on then to the next item on the agenda, which is 6.4. And this is a report from the chair of the Finance and Performance Committee. We do this immediately after the Finance and Performance Committee meeting, which took place last week. And the intention is to really bring to the board's attention and reinforce our attention on the financial situation the organisation faces, as well as the performance issue, but in particular the financial one. That's why the chair of the committee will just introduce the paper to us now. Pass over to John.
Thank you, Chair. As Jan said, this is the chair's report following the meeting, which is held on the 23rd of July. The meetings are held every month, with the exception of August and December, but we will be getting a report to the committee members sent out to us with the situation of August. And if there are any concerns in August, we will be cited on those. So I'll take the report as read. As everyone's aware, all IMs are now members of the committee, and so many people from this table did attend the meeting on the 23rd of July. So as Jan said, I'm going to pass to Catherine, who's going to take us through the key aspects, because there are other reports Catherine will be involved with today, which will be covering the financial position. And at the end of that, if there are any questions, Catherine will be happy to take.
So in terms of the finance position, a brief update now. There is more detail in the IPR, but I'll be happy to take your questions now and summarise that for effectiveness. So this is the first month that we're reporting against the 56 million. As the chair previously highlighted, previous months we were monitoring against our plan, which was 58 million, which we know was unsupported and unacceptable. So as at month 3, on a 56 million deficit, we should have been at 3 million. We're 1.158 million short of that at this point. We are not meeting that. Some of that is around adding the 2 million and savings. So of the 1.1 million shortfall, 800,000 saving shortfall. Now against that saving shortfall at a full year of 3.4 million, we have 28 million pounds worth of schemes in green and amber, of which the vast majority are green, with 6 million in amber, which need to be converted to green in order that we can do the full 28 million. And then of the remainder, we've got 6 to 7 million pounds worth of red schemes in payment that need to be converted to more evidence that we're going to deliver on the savings act. Just reminding colleagues that are new to the this is against 2 billion pounds worth. Some of the C large things that they're obviously need for attention to make sure we're managing. In terms of the operational position, which is where the majority of the money gets spent, we're currently 300,000 over the delegated budgets and where we expect to be at this point. We have 3 pressures really that are coming to bear in that. One that we've seen throughout the year, which is around mental health placements and the high cost placements we've had, and the amount of placements we've been running with at the moment compared to what our reasonable expectation would have been, and also the budget details in the report there. We're also performing on critical care. And critical care for our own population, so this is not critical care that we can charge to our colleagues. critical care provider population, so it's part of it. And the last item is the national insurance funding. We've received confirmation from Welsh Government for the national insurance funding, and like many other public sector bodies, we weren't given full funding. We weren't given, we were given 75% of the amount, which is a 1.1 million pressure that we didn't have for projects. Those are all within these numbers. That 1.1 million. We have to stop there and take any questions.
Thank you, Catherine. Thank you, John. Any questions for Sean?
Yeah, thank you, Chair. Not a question, but perhaps just to add to some of the details in the report. One of the things that we discussed within the committee is the need to ensure that timescales were established to address the shortfall on the identified savings, and there's very much acknowledgement within the committee, the discussions of the need for that. And also the need to ensure that, I can see this report says the workforce numbers reduced by 50 full-time equivalents. We had another reporting committee that gave a different figure. Both of those figures were accurate. It's about when the data was cut. So again, just a recognition of the need to triangulate data reporting. But as I say, Chair, very much acknowledged and accepted within the committee that those positive steps forward will be taken.
Further questions or comments? We will discuss the macro position further, and we will discuss the operational performance figures further as we go through other main here. I think it's really important for the board to understand exactly where we are financially. It is pressure for us, we know that, and we are trying to get enough grip and control in place, not only to deliver what we're after to deliver this year, but any further that we can go as well. And we will talk later about additional possibilities that we might wish to consider support. I have warned you now some of those are quite transparent as well, but we are obliged to try and do something.
So I think, recognising the challenging position that we are in, I would just like to give some assurance about grip and control. So to be at 300k off, ideally we wouldn't be any off, or even would be better. Be 300k off at this point in the year, if we were to compare with last year, I mean, it's like it's a different parallel universe. So just to assure the board that the degree of grip and control on operational expenditure is certainly significantly strengthened, and really as a result, I would say, of the work we did in Q4, colleagues will remember, I can't remember the exact figures now, Catherine, but we were heading quite a substantial miss of our revised forecast, and we actually held the position, but the grip and control that was applied to get to that position was, well, daily and arduous, and much of that has continued. We want to give anybody the idea that, you know, we got to the 1st of April and everybody said, right, we don't want to stop worrying about that. So I'm relatively pleased with the operational position. It mustn't grow, and ideally we bring that back. And I'd say I'm pleased, other than we're heading into the winter, and Paul will give you some reflections as we get into the operational update, but we are experiencing significant pressure in the actual demand for care. So that inevitably has the potential to drive additional costs into the operational position over and above what we may have budgeted for. So that is a concern. I'm concerned that we're in this operational position at this point in the summer. So, you know, that's the thing that's giving me greatest concern with the implication for finances. And I think, you know, I think we have to accept that some of the budgetary pressures that Catherine has just described within the numbers are things that we haven't necessarily anticipated, but that we recognise we now have to find a way to mitigate. So that's obviously a challenge. We'll get to the discussion later. We've got some suggestions about how we might tighten some of those expenditure points, but in reality, the opportunity and the benefit of doing so will be not as great as we did it in Q4. Less
so it's set out as we should.
Gave strong assurance to the cabinet secretary, the DG, in the letter.
We did.
And I think that was an honest reflection of what we believe we can do. So,
Thanks, Susan. Any further comment? You happy to note the chair of finance and performance committee report? Thank you very much. Next item, Matt, 6.5, total assurance framework, please.
Mr. Chair. So as ever, any changes are highlighted within the map itself, and there's been no changes to overall risk scores. The focus remains on how we connect the strategy through strategic portfolio work and bring it into the committees, so that I think it's really inconsistency. So I may comment down off the back of the Finance and Performance Committee last week. We've now got a programme of how long-term, I put finance in there, but I should really have written long-term financial planning, what will come into the committee, to make sure that we keep that horizon, work on the finances as well as the day-to-day that we've just heard. Decarbonisation climate, which forms a key part of our sustainability key risk, which Suzanne's spoken to already today, will feature in the committee. And then research and development, because in that acting for the future strategic objective, which lines up with this committee kind of through the back, if you like, hasn't really had an outlet yet. And actually, when we think about a lot of the partnership work that's been mentioned this morning already, just needed to land that properly within a committee. So those three strategic risk elements will appear every other month. So that's twice a year effectively for each team. We'll go through into the Finance and Performance Committee. Happy to take any more questions.
Thank you. Questions, observations? Is noted report. Thank you very much indeed. We'll move on then to item 6.6, which is Chair's report from various committees of the board. First up, David, is digital infrastructure, 27th of May.
Yeah, I think the report has been great. I think the only thing I probably want to highlight is the capital deployment plan. See that the capital resources have been increased by 2.12 million, taking the revised discretion capital allocation to 70 million. So that also that money is very welcome. Further down in the report, you'll also see the backward maintenance is currently standing at 175 million. It's just sort of starkly highlights the challenges that we've got in this space.
Thank you. Any questions or observations for David? Be happy to know this report. Thank you very much. Charitable funds is next, John. Please.
Yeah. And I think the report as well. This is the meeting, just report for the meeting of the 10th of June. So we've got included in that the annual accounts as at the 31st of March 2025, subject to audit, so they were reviewed. We had an update from Rathbones Investment, who the company look after the charitable funds investment fund, and that's the biannual update. And the only other item I'd like to bring to the attention is the decision to go ahead with the hiring of the head of fundraising. That's going to take some time. I'm not sure if Catherine would like to say a bit about that aspect, but other than that.
Thank you, John. Did you want to add anything?
No, we're just in finalisation.
The important is one thing is that if you get the right person, the right sort of work. Thank you. Questions? Happy to note. Okay, the next item is quality and safety. Kerry?
Okay, the committee received the analysis from deep dive on nationally reported incidents, and where there were some common themes which had emerged. We were also advised that the Shaping Our Future Quality Excellence programme will now be driving forward the actions which are needed to try and avoid some of those events from occurring in the future. Suzanne alluded to the electronic prescribing system, and that will obviously help with a number of the issues that the Health Inspectorate will also relate to this too. We had a presentation on prevention of future deaths, which have emerged from coroners' inquest reports. There's work being done in that regard, and also on infection prevention and control, where we need to do better. But again, the electronic prescribing system will help in that regard. So the committee, it was a full committee. It's certainly not complacent. We want to try and reduce the prevalence of nationally reported incidents, and the work of this quality excellent programme will enable us to do that, looking at a number of areas and number of projects within the programme to address the quality concerns moving forward.
Thank you very much, Gary. Questions for Gary? Happy to move this report. Thank you very much. Next item is People and Culture Committee, Sarah.
Yes, just to add to the staff story, Nina, who came and who shared her story, is one of our overseas recruits. And we know that. So actually, it was a fantastic story, how she'd been included and then that comes around her. So it was a brilliant story of demonstrating a number of things that underline our values. You'll see that there is, a really strong focus on workforce, and going back to the discussion on finance, we know that that's our biggest asset, but also our biggest source of funding. We continue to look for ways of sort of formulating that our savings and financial position, and also implementing to culture. We do that, and there are some very difficult issues. For instance, you'll see that there are more budget misses than vacancies. There are, I'm not sure what the position is, but it looks as though there are more training doctors than there are training places. So clearly, there are difficult phenomenon factors at an individual level. And we continue to look at culture and safety and think about that context. So we just visits, obviously that's safety and that ability to speak up, which was demonstrated through in the theatres, is very important. So we might not like what we hear, but we should be doing. We need to do it.
Thank you, Sarah. Any questions or comments, Rachel?
To comment, I just because it's the last public board, I'd just like to thank Sarah for being a brilliant chair and scrutinising all of the data, but in a very transparent way. So just thank you very much.
Well, I mean, it's been really great to work with the team, and I think for instance around psychological safety and culture and so on, there's some quite difficult stuff to cover and to get some metrics on. The team is so great in that they keep on learning, changing, and developing. And that's a real joy to see.
Rachel and Sarah. Happy to note. Thank you. The final chair's report is audit and assurance, Rian. Okay. Right. I've got one item on my list here, which is audit insurance for the 20th of May. Not on your screen. Okay. We'll pick that up at the next week. Okay, thank you very much. Next item is strategic planning 6.7. This is the commissioning and partnership update. Catherine?
Yeah. So I'll just take us through the multitude of activities that are going under strategic plans and portfolios, commissioning partnerships. Recognising Emma's not here today, but I may wish to add to that. So under the strategic portfolios, the first element of the report there is just really talking about how we're trying to
move into a much more longer term focus, move into what would it take to deliver our strategic ambitions, our strategic objectives. And you can see there's some dates and some milestones as each of those elements of the strategy and those key drivers of change are being worked through by the relevant execs with a portfolio chair who is not in their group, and culminating in bringing that back and seeing it all together with Suzanne's oversight to make sure that we're making sure all of the pieces will move us in the right direction, right timescale. Spent some time as part of this year's plan, and you'll see that later on in the agenda, highlighting what the big strategic things we want to do this year in order to move us along the journey to look towards delivery of the strategy. We've already heard some of them mentioned, for example, the excellence driving that change that we're taking the shape that we want. So that work will continue through this year and feed into next year's planning cycle, but also as a board, I think we would expect to see something a bit more material about how do we get the 5-year plans and how will we get confident that we have a strategy and we have the steps, any flight systems to make sure we're going to deliver on that strategy. And clinical services plan going to be key in that, and through that is also key in much more debated in Accommodation. In terms of the annual plan, obviously we've talked about finance already this morning and some of our delivery concerns and issues, and we'll go into detail on those of the IPR and the update on the annual plan. Suzanne's already noted that we've increased in our escalation, and so I won't really focus on that any more in this session. We have been written to by the Cabinet Secretary and head of the NHS for Wales, and we need to apply for the case of this to our position and to a conversation. In terms of regional planning, there's quite a lot of work going on under the setting up joint committee with the first meeting in October, and the pre-work work is happening at the moment, which is why many colleagues around this board and that work is evolving in a shape as we start on our joint committee. That doesn't mean we're doing nothing together at the moment. We already have a committee, and we need as Southeast Wales region and the activities taken at the moment focus mainly around health park, which supply places across the P with theatres and the road. Has been subject to conversation due to an assurance report that was commissioned by the Welsh Government by the state. That's been managed carefully with colleagues at in terms of other activities regionally, the ophthalmology, there's some stats in there about the ophthalmology work last year and the ophthalmology priorities of this year. That does not rely on our individual health board and support what we're here to do. You can see that pathology at the moment is still being developed and stage. You can see an update there on Velindre and the Velindre Cancer Centre and how that feeds the wider Southeast region. In terms of, there's some updates there on commissioning. You can see the work that we've been doing with the Regional Specialist Services Partnership with Swansea Bay. But we're getting to quite a crunchy point with some services, which I think it's fair to say are too fragile to continue. As such, both ourselves and Swansea in tandem and in unison are having to be very specific about what we can and can't do. And I think it's fair to say there's rubber round on that at the moment, and it's sitting quite interesting. But continue to sustain. But I think there's probably more time series that was into purposes. But it's very necessary work. It's hard work, but actually that's the best position to make sure that we're starting without that. And so then there's an update there on the Lindra Cancer Centre opening, which the radiotherapy satellite unit, which is in the Went area recently and started working. So that's the first step for a sort of wider estimate in the fall. And an update on the joint consultation. Then there's more of an update about engagement and what we've been doing around engagement and co-production, particularly again into our services plans and how we want to develop into the future, making sure that we're consulting with patients, staff, and using babies, children, we go through the test there to do some of that work, find out what works. Then the work of the Regional Partnership Board is outlined there, and the event that took place in May to celebrate the work that's been happening, and as we need to look at how we use our assets, we've already decided people resources, our place resources, and our services.
Thank you, Catherine. Are there any comments or questions? Bill?
Yeah, yeah, just wanted to pick up my understanding has always been that this is the first sort of tangible action implementing the new strategy that we have. I think you've confirmed that on the Could you expand a little, provide more context on how that implementation work is going? Because that's a plan. The next step is to implement, monitor, evaluate the plan itself. These are, as you mentioned, a bit of a test case or test bank for developing other implementation plans, other aspects of our overarching stuff. It's been quite a while since that plan has been conceptualized. How are things developing?
So the teams in strategy and planning are working with the teams in the clinical board to work through and develop what are the detailed action plans in the delivering of. Obviously, we signed off the strategic plan, but now it's about, okay, what are we going to do in what order? What are the milestones and who's going to do what? So that piece of development work about what is the detailed plan, what's going to happen, that's the development work that's happening at the moment. We should then give us the robustness to say, okay, this is how we know we're going to do it. Quite how we read the detail of service plans with the partnership working and working more in the community. It's a bit of a sort of matrix lattice, and it's sort of it's going to take some working through and lining up, because the danger is that we need to make sure that the clinical service plan aren't so conceptual that we don't actually deliver anything, but aren't so detailed and specific it's going to take us forever to get to the end. So that thinking work's going on at the moment. The clinical colleagues what's best practice, and I think we'll come back with a plan and a time scale range how to do that in a time scale. But certainly focusing on the community and where we know we can get population health benefits is where we're going to get biggest bang for our buck.
Please.
Yeah, just to reassure that we're actively working on the joint academic health sciences, simply called Cardiff Health Partners, work with into this. So we're hoping this is a test case in terms of trying to involve universities more generally in the delivery of this particular strategy. So again, hopefully that will provide some framework by which we can do things in the future.
Thanks, David.
Yeah, it's the same point you raised, Steve. That's just to say that's on train. But to your point as well, you know, the last meeting, it goes from general to actually specifics. What does that actually mean, and what does it do? So talk about the last one.
Harry?
In terms of commissioning and the joint committee, are there risks that the government funding will be affected by the fact that Betsy are using north-west providers who are charging high prices, and we do not necessarily get the same level of funding for procedures that we undertake as previous providers?
I mean, that is absolutely an issue. The focus that goes to the cases. We know that there is and that tariff is set and not negotiated. So therefore, what happens is essentially the JCC is ultimately reduced by that, which means that when we have actions to deliver services in field, we need to make sure that we've got scale, got sustainability, big population size, and some of the east population, because it would naturally fall to a different provider, it becomes very tricky to run sustainable services, even though I think there's double down there. One, the resources reduced. Two, the cost of providing a sub-5 million population for most of the things you'll be a specialist. Almost know that the cost will go up. Then you've got the whole ability of the system.
Thank you, Gary. Gina?
Yeah, thank you, Chair. And a really good question about how we turn conceptual plan into a service plan. So that's what you're sort of pointing at, and then you're right. And colleagues have given you some sort of reflections on that. I think to the point that Kerry's just made, you know, we had this discussion at the last formal board with our JCC colleagues. There is an absence of a strategy for tertiary services for Wales. So that piece of work is absolutely urgent, and I have personally been lobbying around the show for that. And I'm in fact meeting the chief executive of the JCC on Friday for further conversations. I'm sort of keen to get it going. I don't want to undermine the role that he has in the JCC, so a bit of a hurry up conversation possibly on Friday, because it is so material to everything else we do. And then, you know, we've got the complexity is so great around this. So if you look at the documents we've shared with you around Improving Together, which is the most recent iteration of the Cabinet Secretary's directions of travel, you know, there's quite a bit in there that will be influential on this service plan. You know, a new review of maternity services, a focus on women's health, a review of neonatal services, which doesn't take a very long time. You know, these are the contributing factors, but are really important for us because we're often kind of a key, or you know, deliverer in terms of that, certainly for our own population at the regional level. And then there's the whole piece about and how do you deliver sustainable and care in a community that meets families' needs, which is a different question from how do we deliver healthcare to children and families and babies. So I think we've got layers of activity and thinking going on. There's work going on in the partnership space around the use of the state. There's an opportunity there to maybe reinforce the community pediatric nursing. If you look at the numbers of complex children now living in our communities, largely as a result of fantastic neonatal intervention, where neonates are surviving, often with great disability, previously wouldn't have. There was very little capacity in the system to respond and meet those children's needs and support those families, which they need huge amounts of support. So we've really been having, you know, Paula's been leading a conversation with that team to understand what do they need, how can we support them, meet demand. You know, and often these are lone workers in families' homes, you know, very challenging circumstances. So the layers of complexity are significant, which I think speaks to your point about trying to really understand what can we do well, quickly, that will make a material difference whilst not undermining the delivery of a longer term opportunity. I'm balancing everything. It might be the theme of the discussion today, because balancing multiple taskings and priorities is a good thing. And then trying to keep an eye on the prize, as it were, the longer term benefits.
Thanks for that. Further observation, questions? Okay, if not, I'll move on then to the recommendation. We'll be happy to note the progress being made across the Strategic Planning Commission and Partnership portfolio. Thank you very much indeed. We'll take up one more item and then we'll have a little break. We didn't get another word again. So we move on to 6.9, which is monitoring the annual plan. Just to alert colleagues, although this table features under review and assurance, there are some approval items within the recommendations. Catherine? Yes, please.
So this is just to bring to colleagues' attention and raise awareness about all of the multiple ways in which we monitor these. That will come on in the private sessions, talk about all of the different versions of that, which I think are all sort of live in this. But in terms of where we stand with the plan that we've signed up, you can see in terms of the elements we've signed up to, where we monitor, frequency in which we monitor, and where you see that information. We've been working hard as a team to try and pull it into one place, but as we've already talked about, there's some very strategic things we want to do, and then there are 200 actions in the plan that all need more level of detail, and how we form the IPR and the other documents of things that are strategically important to us, but also might not be on the minister's to-do list at the moment, is the balance we're trying to pull here. I don't think this is the finished article, but it's a start of the 10, and it's what we'll work through as we try and develop the products to help easily at detail, but also at summary when we end up going at those different ones. So I'll be willing to stop there, take any queries or questions. But fundamentally, the things that are longer term measures, we sure for a longer time frame, longevity, things that are really important now, and it's just.
Thank you, Catherine. As Catherine said, this is the start of the 10, so to speak. We'll refine as we go forward. Any observations or questions for Catherine at this point? Okay, are we happy to approve proposed monitoring arrangements for 25-26 annual plan? Thank you very much. Thank you, Catherine. Colleagues, should we take a break now? It's 10 to 11. Should we reconvene at 11? Thank you very much. Okay, you're all ready. Okay. Give me a signal when we go to my sheet.
Yeah.
Please on all, I'll go back everybody. We're now entering item 6.10, 6.10 on the agenda, which is the integrated performance report. And the first step on that is finance and cash.
So I just brought people's attention as of the second. We already say the position what we need to do in order to. So we have to stop there and take any.
Okay, thank you, Catherine. Are there any questions for Catherine? I know that there are a lot of good scrutiny and challenge to face in the finance performance last year. And it's a very good report as well. Surprisingly, not showing the question. Okay, if we're happy with that, we move on to public health. Claire?
Thank you, Chair. So as usual, I will focus on the big three priorities that we have in public health. So obesity, vaccination and smoking. And we've selected those as a reminder for those who are new to the board, because they will help us reduce health inequalities. So we know if we tackle those big issues, that will make a difference in that area. So the first point that I'd like to bring to your attention is the child measurement programme, which shows us that we've made a slight improvement in the percentage of children who are a healthy weight from 77.5% to 77.7%. So we know we're moving in the right direction, which is great. And we've stopped that deterioration, which is fantastic. However, the difference between the most and least deprived groups still remains a concern for us, and you'll see the pie chart on page 127 that shows that difference quite clearly. So we've got a 9.9% percentage point difference between our most and least deprived groups. So we will be working on that through the Good Food and Movement plan. I'm going to move on to the Diabetes Strategic Programme Board and just let you know that this group met again this month, and we're focusing on 3 foundational pieces of work. One is around maximising health outcomes for people with diabetes, and that piece of work identified 6 areas and 6 recommendations, and each of those has now got a work stream lead, so we'll be taking those forward. The second foundational piece of work is the health needs assessment, and that's just nearing completion. The final piece of that jigsaw puzzle is the patient information that we're just collecting from survey. And then the third area is the pathway mapping, which I'm really pleased to report has now started because we've got support from the Shaping Change team, so that's great. We will be focusing on the 8 care processes that happen in primary care as well, and we've established a working group around that. We will be having a deep dive on diabetes at the August board development session. And when we did that piece of work at the RPB, that generated multiple follow-up meetings as well. So we'll be having that here. Moving on then to vaccination, I'm really pleased to say that the community model of care, which I've talked about at previous meetings, which addresses that accessibility of vaccination, is really proving effective. So we've gone from being bottom of all the league tables to at least the middle, and we're now above the Welsh average for most of our indicators with regard to vaccination. We're finding that taking the vaccines to people is being a really effective methodology and proving successful. So I'm really pleased about that. Measles still remains my biggest concern. So the uptake of MMR is still needs some work, but we are planning a back to school campaign. We know that the period where children go away on holiday and they might go to countries where measles is endemic and come back and then mix in schools is a real high risk area for us. So we'll be focusing on that. We're also working closely with schools and communities to boost the HPV vaccine over the summer months as well. So you may see our vaccine mobile unit now going up and in the local communities and vaccinating people. Then moving on to smoking, we still have 13% of our population who are smokers, and we're looking at new and different ways and alternative methods of trying to reach those people and support them to help quitting. And people often ask me, so, you know, when will we see the benefit of somebody stopping smoking? Well, just to give you some idea, after 20 minutes, your pulse rate comes back to normal. After 8 hours, the carbon monoxide that's built up in your blood actually reduces by half. At 2 weeks, circulation improves, and between 3 and 9 months, that coughing, wheezing and breathing problems that people experience begin to reduce, and you actually see lung capacity increase again by 10%. And at 1 year, the risk of heart attack is halved. So bringing us back to that patient story, it's so important that we focus on that area. Just to finish off then with the Women's Health Hub, we've got a steering group across the clinical boards and the third sector that meets monthly. We submitted a funding bid to Welsh Government to try and reach our aspirations, and they've come back and said that will be funded. That will fund a health needs assessment, a review of waiting lists, and also some staff training around women's health needs. And a further bid will be submitted next month. On health protection, the only one thing I wanted to draw your attention to is regarding a UK-wide exercise that will be happening over the autumn, that will be testing the UK's preparedness and capabilities and response strategies in the context of a potential pandemic. And I will intend to bring a report back to either a committee or the board after that event has happened to share the learning about that. Thank you.
Thank you very much. Any questions or observations to Claire, please? Yeah.
Thank you, Claire. With regard to the diabetes 8 care processes, where is the data reviewed of how compliant we are with each step in that process pathway.
So the integrated performance report does contain a high level bit of information, but now we've broken that down, and that working group will be looking at each of those care processes and how well we're doing against those.
So I think the level of interest is being paid to it, certainly within improving together documents and stuff, it would be useful to incorporate our compliance with each step in that pathway here.
Absolutely.
But also, probably most importantly, and if it's in here somewhere, we just need to draw it out. That might be, I didn't spot it when I was looking. Because there's something about compliance with each step, but actually it's the bundle that we want to get to, isn't it? Like to see compliance in the whole bundle.
Yeah.
So would that be possible?
That's fine. Yeah. Thank you.
Thanks. Terry?
Claire, thank you. In terms of vaccination amongst staff, we're not exactly hitting targets. So can you give us position statement, as it were, where we are in relation to what we're seeking to do in order to maximise staff compliance?
Sure, thank you. So we have looked at what's best practice internationally to find out, how can we improve our uptake of staff vaccination. We're also at the moment, we've got a survey open, and for those of you who are on our system, you'll see it appear on your screens at certain points. Looking at, for those people who didn't have their vaccine last year, we're asking them questions about why didn't you have your vaccine and how can we support you to have your vaccine. So we've got the survey that's ongoing. That closes, I think it's next week. We're also going to run some focus groups and interviews with people following that. So we've got 150 people of the 800 who've already replied who want to come and talk to us about their vaccination and why they didn't have it last year and what could support them. We've already started planning for this year, for obviously next winter, and it will be flu that's available for staff rather than flu and COVID. So there'll be one thing to focus in on. And we intend to be using the roaming model, as well as having fixed points where people can get vaccinated. We saw the highest peak ever in terms of uptake in the first week last year, which was fantastic in terms of people wanting to have their vaccine, but that wasn't sustained over the long period of time. So what we need to do is try and reach out to people who can't leave their clinical areas perhaps and go to them as well. So we've got lots of things on the go, Perry, to try and improve that uptake the next time around. Thank you.
Other questions? Thank you, Claire. We're going to move on to operational performance, which is a big slice of the report. So Paul, over to you, please.
Yes, thank you, Chair. So I'll start with just to say, we've got the new look report now on the second iteration of this. So it'd be good to get some feedback at some point, but hopefully all members will find this a bit easier to navigate and pulls out some of the highlights. Yeah, I guess. I suppose just reflecting on your comments earlier, Chair, about kind of morale and keeping the sort of heads up. I think what we found, particularly in the urgent emergency care, is the summer's been unexpectedly challenging, more challenging than winter in some respects. But when we look at the data, we are holding our own. I think the disappointment is that we're not really improving as we would have expected to or hoped. I mean, there's some things we've done a little bit better, but if you look at the wider context of A&E and ambulance handovers, 80% of patients are handed over within 60 minutes. We still have our red line of 2 hours, which we try really, really hard to hold. Don't always hold it, but we try really hard to hold that. And we do remain best in Wales on a consistent basis for ambulance handovers. But we know there's more to do, and we have signed up to work towards the 45-minute standard that came out of the Ministerial Advisory Group recommendations, and we're absolutely committed to that. So yes, we would want to be better than we are. I guess we are holding on our position at the moment. In terms of 12-hour waits for patients, again, it's not materially worse, but it's not improving, and we're still too high. At just under 8% of all patients who come to A&E waiting. The bit that is unacceptable, and which I actually want to apologise for, is that in June we had 34 patients wait over 24 hours in our E department. That's not acceptable, and so I would like to apologise to those patients and families for that poor experience. Almost all of that is in due to our inability to create inpatient beds for patients in the EU. So it's not an EU issue, it's not EU's fault, it's the fact that those patients have ended up stuck in the EU, not being able to discharge patients on a timely basis. So what's driving this? We don't quite have the answers to this yet, but we're getting closer to being able to explain it properly. What it absolutely isn't is pathway of care delays. So we got the latest pathway of care delays only yesterday, and they're the lowest that they've been for over a year. And if you exclude the mental health pathway of care delays, so the patients that affect the acute beds that directly affect the EU flow, they are the best. They've been 115 patients, of which just 2 are out of area patients. All the rest are part of all area patients. Those 115 patients accommodated 4,000 bed days, which sounds a lot, is a lot. That's a 35-day average delay for those patients. So there's more to do, but what I'm saying to the board is this isn't the reason that we are struggling, because that position is actually improving. And the number of patients waiting for adult social care, either assessment or allocation, is 49 of 150. You've seen that number in 100 previous meetings. Just to give a couple of other figures, 21 of those patients are due to either disputes with families in terms of where is the best place for the family to be placed, or needing court protection or best interest meetings. So I think what we're finding is that with the focus we've got on, the patients we've got left are complex. Not to say we shouldn't do and can't do more, but I think some of those improvements we've seen and then the pathways have allowed fewer patients to be here. For those that are here for a reason that's more difficult to. So if it's not pathways of care delays, then what is it? I mean, basically, it's our high occupancy level in our medical specialties. Surgery and specialist surgery are there's a bit more they could do, but their length of stay is relatively. Medicine is still 1.5 days on here average. That drives high occupancy, and that drives further inefficiency. So we had in last week, we had the most number of medical patients in the wrong place, medical outcomes, than I think we've ever seen for a number of years. I mean, almost 60. We've not even had that in one. So we are doing a bit of a forensic review of what's driving this. We had a reset week last week, which had some limited success. And Kerry was just talking to me earlier on about looking at the clusters and where some of the demand is coming from, quite a lot of variation from our clusters about users and tenders today. But the big challenge that we've got, and David is helping me, is if you come to EU and you need to be admitted, if you get to the acute wards, there's a really good chance you'll be turned around. If you need to stay after maybe 5 or 6 days, that's really when the delays start. And we've got a big challenge around the kind of 7 days and beyond. So that's what we've really got to focus on. And I think we said this for Finance Performance Committee, but my suggestion we think that a bit of a review of what's happening with the demand as the attendances and then stay on the next Finance Performance Committee, and more importantly, 4 or 5 things that we're going to do get us into a better shape to go into the winter. So that would be my reflections. Is that we're holding our own, but we're not making improvements that we should be making. That is making things more difficult than we should be as we go. So just move on to plan care and diagnostics. The cancer is really interesting and of some concern. So the demand continues to grow at a rate we are struggling to manage. So the number of patients we are currently tracking on a single cancer pathway, patients with suspected diagnosis of cancer, is the highest it's been now since August 2022. And that's around 2,738. That's patients more than we have the previous number of patients. It's not because we haven't got the capacity, it's not because we're not seeing patients, it's because the demand is really high. And of those 2,700, over 500 are skin patients. And we just need to do a bit more work nationally, and we are working with Welsh Government colleagues. So the perception, we need to prove it, is that the sort of drier, longer weather is resulting in more referrals in for suspected skin cancer. Now, of course, until these patients are seen and examined and biopsied, we can't get a definitive diagnosis, and most of these patients on this pathway thankfully won't have cancer. We are just struggling to make that diagnosis at day 28. And we're starting to see some of the backlogs for patients increasing. However, that said, we deliver over 70% once the forms have been refreshed and made. So again, despite our challenges, we are still consistent in our delivery of the cancers and the cancer pathway, but albeit we haven't delivered the 75% standard. The hotspots are urology, but we are seeing improvement, and we expect that to continue in September to really improve. Skin, I've touched upon just the volume of patients that need to be seen in a timely way. We've got some issues just with breast capacity. Some of our recent additional appointments haven't quite worked on the way which we intended. But we continue to work with clinical teams and to really keep looking at our pathways and make sure we can find the national standard. So I think cancer will continue we just continue to require a lot of focus and attention. In terms of the planned care and the 104 week waits, and this is where I need to not be defensive, because we were called out from the second highest number of waits in Wales. So we are absolutely where we said we'd be. We're better than this. So we are continuing to deliver or exceed our agreed trajectories with Welsh Government. Patients waiting over 2 years. So at the end of June, we had 1,400 patients waiting to start treatment. That was against a trajectory of just under 1,600. So we were better by almost 200 patients. By the end of Q2, so by the end of September, we committed to having no more than 996 patients. And obviously, as we get to March, that number needs to be 0. So we're doing what we said we'd do, and we are getting good feedback for that from our colleagues. Also, just about to starting ophthalmology, but about to start across our other specialties, is the additional capacity that's been bought by Welsh Government to drive down the waiting times for outpatient appointments and reduce the number of patients on the overall Welsh waiting lists. We've got support to see an additional 33,000 new outpatient appointments. That's being managed through an insourcing company who's been commissioned by Welsh Government, but they're working really closely with our clinical teams. And we had a brief conversation this morning with David at the company and some of our clinical directors. Clearly, where it works best is when our consultants are involved, because it's the aftercare and the follow-up. But we recognise that this is an opportunity, and we just need to make the most of that to reduce the waiting time. Just move on to diagnostics. I think this is the bit where we should really be confident in what we're doing. The non-obstetric ultrasound, that got called out as a specific issue in the back report and the advisory group report. In the middle of May, we had 7,800 patients waiting over 8 weeks for an ultrasound scan. As of last week, 6,136. So we've taken 1,700 patients off that list, and we are confident that we will get to that 0 position by the end of March. So that is really good news. And we're seeing consistently week on week reduction in patients. Endoscopy was our other big challenge. Welsh Government have allocated us just over £4 million to address the 8-week wait issues. Half of that money is to use the mobile facility that Untitled have got, and the first patients will be seen and scoped there from, I think it's the 3rd week of August, mid-August, 3rd week of August, and the rest of that money is for additional insourcing for those patients to be seen in the UHB. So that's a significant amount of money, and our challenge is to get the most productive, efficient use of that money to treat as many of those patients who are currently waiting every week. Just a couple of other things on diagnostics. The CT weights and the MRI weights did go up. did have some fairly significant state equipment failure issues. There was a water leak at UHL on the MRI scanner. That meant we lost quite a lot of scanning capacity for a number of days, and the leak was so significant that it was £150,000 to repair it. So when these things go wrong, they go wrong. The CT scanner in EU has been out of action on a number of occasions. Whilst it's only 4 years old, it works. It does all of the work for the EU, the MCC, suspected stroke patients. It's a real workforce. I think we do need to have a look at our overall capacity. It's not machine breaking down, but it's not good. Breaking down is doing far more work than the other. I said that CBT are very popular. Just a couple of other things to say before I stop. Obviously, you'll see in the cover paper that in terms of our community, we're continuing to build capacity to try and prevent patients from needing to either go to the GP for consultation or to access secondary care. Some more single spaces in the pharmacy. Our safe at home and virtual wards are increasing as well. Once we've put some additional support into weekend cover for the district university, now we've quite some uptake in that. So that is very much in our strategy, is to continue to build up community capacity. Mental health pressures, the pressures continue, particularly with the development waiting and demand. So that's a bit frustrating in a way, because we were given some additional normal current funding, which is very welcome. You'll see from the fact that the waiting list does start to come down and the number of assessments shot up. We were told that money was normal current, we've been stopped. The Welsh Government recognised that. We're just continuing to work with them, because we cannot have, we don't want to have children waiting every 4 years for an assessment, but it's a big capacity and resource issue that we're working with. What else was I going to say? Just on mental health, we've recently just commissioned some additional support to help us review our models of care and how we provide community inpatient services. It's a small piece of work. It's a kind of come in, work alongside our teams, live a discovery phase, and then we'll have that report back in the early autumn, and then we'll take a view about how are we doing, what does good look like, where might some opportunities be for improvement, what are we doing really well, and that's been really so I'll pause there, Jane.
Questions?
Yes, thank you. So a little bit stuck in there, and as you say, holding the position in the situation is heat. I just had a couple of questions on the bed availability. So, I mean, what's really helpful is helping about data and collecting that data, and then you've got a real insight what might happen. I guess the issue is, what's the solution to that? Is it more beds? Is it different beds? You know, where does that fit when we come to talk about our financial position? Maybe using beds. That's one question. Then the second question is about endoscopy. In-year solution is really that there is a systemic gap in endoscopy capacity. So is there any indication that might be addressed?
Yeah. Okay. Thank you, Sarah. So in terms of the second question first, so the Lancashire Health part is designed to be the recurrent solution. I think we put in there with something like 17 sessions of lists of short of the current capacity. So the 4.2 million is for the backlog of 8-week cases, and we didn't have a solution for that. And then we saw that the UHB was a recurrent solution, but what we'll be going to do with the backlog, this is going to help with that. So when the LHB comes online, etc., is still to be completely determined, but we do have a line of sight on that. I do take a lot of part. With a lot of positive ones. A year ago, we just didn't know how we were going to treat them, so that's good. In terms of your question about beds, so the bottom line is no, we don't need any more there. It's very tempting to open a ward, and that would be great because that would solve my problem today, but it would fill up. We wouldn't have any more doctors really to look after these patients, and they would just stay longer. Should we take beds away and drive some of that efficiency? Well, we tried that. We have closed some beds and just spread out into the surgical specialties. I think, you know, where David and I and support from Jason and Emma is we really need to reframe the conversations with our clinical teams, because whilst only they really protect this, the doctors are in charge of the care, but actually, you know, they're not the only people that do discharge. We have the therapists and professionals discharge. We have nurses discharge, and sometimes it's a bit confusing about, well, what is the plan for this patient? That's the bit we've got to go for, because if you get into our acute medical wards where we put a lot of investment in, the short set, actually the turnaround is really good. Improvements there. But if you require to go into a specialty ward or a care of the elderly ward, really then it's really unclear when you will be discharged. And you know, so we've got that challenge between day 7 and beyond. So could you know, would more beds help? Yes, it's a wonder. I mean, winter's a bit different. We know that the demand goes up a bit. We know the length of stay increases, so we do need a bit more capacity in the winter meetings. But it's not the solution. It's not actually the solution that we need. What we need to do is create efficiency capacity we've got, improve our length of stay, get to at least average, and then we can draw a breath and then review whether bed capacity is right or wrong. So that would be my take on that.
It's really helpful. You said there were 60 outliers.
That was the beginning of the week.
Yeah, so there, is that also an issue being orphaned in the wrong place?
Potentially. I mean, what we have done is put in additional support. So there is a team of people now that hire a consultant who go and view those patients. But then that's 2 wards of patients and itself, and they're not in 2 wards. They're in
all over the place.
And that's come down now, which is good, but it just drives more efficiency. Every time you outline a patient is staying a day or 2 longer than they would have done.
Thank you, Paul. Thanks to you and Dean. Well done for kind of pointing out the delayed pathways of care data. So that's a partnership piece, and I know that you've worked really hard with everybody around that. So well done to you and your team, also to the partners who have contributed to that, and we should definitely make sure they hear about that position. And I think it is useful to draw that out, because you know it's easy for us in the hospital to say, well, that's the reason we're in difficulty. Well, that's not the reason we're in difficulty. And I guess what you're telling us is we're not 100% sure why we're in the difficulty. We've got some assumptions, some beliefs around continuity of care. You're absolutely right. Patient oversight out in the specialty bed base is a challenge. So, and I know you, David, Emma, and Jason have been looking closely at the data. So maybe at some point when you come to a view, what it is, because to Sarah's point, that we need to understand what it is before we try and fixing it. And so that I would really welcome if we can understand what's driving that position. But you know, there are demographic factors. There is, you know, we've got an increasingly vulnerable population, and so I'm sure that was really. Thank you also for picking up neurodevelopment, because I was going to sort of ask you what our reflections are on where we are. So, and I wonder if at some point we could have a bit more of a detailed brief about what are the next steps in the context of a bit of a change of policy around the approach to this, and where's that taking us? Then my last question, and again, it might not be that you want to answer it now, but outpatient transformation. So I looked at the SOS and PICU data, which didn't give me a little part. It's just flat. And yet we've been talking about that's a key enabling action, isn't it? I know there's been work, but I wonder if we might have a deep dive either at one of the people here, kind of in a space, kind of what is the approach to outpatient transformation? Because there's a big piece in there about demand mitigation. It's not necessarily in outpatients, but part of the work, isn't it? And then there's the work about how do we manage ourselves in patients, what's our approach, and if we can address the referral issues we've got, rates, and obviously our treatment pathways become a little bit easier, don't they, and quicker. So that was just a question.
I see that.
Yeah, no, thanks again. You're absolutely right to call that out, and I will answer it, but it's not good enough, not where it should be. But we had a conversation in the quality meeting yesterday about outpatients, and you know, obviously theatres is our top priority in terms of treatment change resource, but outpatients is number 3 on the list. So we've agreed to do a bit of a stock take about what are we doing, what is the plan, and what do we need, who needs to do what, because you're right, we're just sort of talking about it really, and not, you know, there's such an opportunity there. It's more of, for me, it's more about creating capacity, all the OG follow-ups, to stop the patients just being put on the list and we're never getting to them. So I think it's very challenging, and we need to come back and tell you and the board what we're going to do.
Can we pick up on Suzanne's request for deep dives on neurodivergence cases and other patients? Bearing in mind that the Minister for Mental Health has provided some instructions for us about how we use existing funding and additional funding, that would be very good. Thank you. I've got Susan.
Well, thank you for taking us through that. 2 questions picking up on issues that have actually been raised already. One is around the children who are waiting for support from the neuro. That was as I raised this issue, as you know, in the committee earlier this week. If they're waiting in 3 years, is there a risk that they become adults while they're waiting for that assessment? The answer to that question was yes.
Yeah.
So it's just about the importance of ensuring there's a plan for those children. What happens to them? Do they then go back to the beginning of the waiting list for adult services, or they transition across? So in terms of the deep dive, it would be really helpful if that information could come back to the board as part of that.
Yeah.
So thank you for the information around what's driving delayed pathways of care. Really helpful to understand this. That puts the board in a position where we're able to see the effectiveness of partnership working, which is absolutely critical. My question in relation to that is, in terms of, as Suzanne has mentioned, those patients who are, we're seeing more patients who are more vulnerable, therefore potentially more patients who need support from protection. And you reference that that's one of the drivers for delays. So how are we able to influence the speed with which fraud protection acts? Where does responsibility rest for having that dialogue with the court around not just the cost implications for health boards, but obviously also the impact on patients who potentially sit in hospital beds so they really don't need to be there?
Yeah, thanks. Good question. It's taken us a bit of a while, I think, to understand that fraud protection. I mean, I'll be totally honest with you. This is my layman's understanding. It doesn't make sense. So, a patient doesn't have capacity. That's agreed. Best interest meeting. That's agreed. Families say, "Okay, we're going to put mum in the nursing home. Mum, I don't want to go. Go to fraud protection." But we've already agreed to the contract. The fraud protection will say, "Yes, that's correct. You can put her in the nursing home." That seems to be something that's become more prevalent over the last couple of years. So, you know, we've gone backwards and forwards about can we circumvent this. No, we can't. I don't think we've ever come back and challenged the court protection about the time series. I mean, I've talked to social care colleagues as well about how we might be better placed to have a conversation. But I wonder whether it's just an increase in demand for delays. It's not always that the court protection are delayed, but there's quite a lot, and Jason can help you with this. There's quite a lot of things we have to do to prepare for court protection case, and that includes having an endpoint identified. So you have to be able to say this is exactly where we want this patient to be placed, rather on this date, etc. So I think it just adds time and process that we never used to have to do. Yeah, that's my understanding, Jason.
Can I bring Matt in on this?
I mean, I don't deal with this as frequently as you basically. The times I've been brought in, I think there's an element of risk management to it as well. And I think there are differences in how we deal with these things and how we engage with the two different local authorities there as well. I don't think there's ever been an issue that I've seen in terms of court protection typing. I think probably so the source of it is, well, how do we find ourselves in conflict between the expertise of the disciplinary teams, the family sometimes, and then who is prepared to have the confidence in the multidisciplinary teams to make appropriate decisions? And I think there is a degree sometimes of risk being delegated up into a court to make a decision because it's quite hard to make a decision at that space. So I think that's probably the thing.
So I think those things have always happened. That's always been a bit of the other tension when nobody agrees. But the bit that we're seeing is new is everybody does agree. Apart from the patient who looked passively, we still need to go to court protection, and that was something we never used to do. So I think that's why the numbers double. Those complex ones we've always had, but this is the extra process that we now navigate.
Yeah, thank you, Ian. Thank you, Paul. As you explained, Paul, it's a really complicated thing understanding what's driving some of the issues. But I just thought I'd bring us back to this is about quality of care at the end of it. And actually, the patient story is really germane to it. You know, that patient had immediate hospital intervention, and therefore had an incredibly short stay in hospital and came away unscathed. I suppose some of the data that I'm looking at, some of these issues that are driving, we are delaying the care. So if you look at our thrombolysis rate, it's 11% rather than the target 20%. If factor transfers to the wall is reduced. What these do is these people are more debilitated and they take on the level. We have to recognise that that's what we need to really start getting hold of. Because that's the role of university hospital wells, is to deliver fiscal interventions in a timely way to make sure people recover from their illnesses. At the other side of things as well, there is the elderly population. Spending more time in hospital than they need to is also very devastating for them and their recovery. So just wanted to say that these things, and this is why Paul, Jason, myself, and Anna are working so close together. This is a quality issue, and sometimes people do think more beds, more length of stay, the safer thing, but it's actually driving congestion and harm.
Thank you. See, a lot's been said, but I'd just like to commend Paul on the clarity of the presentation. I think the data is clear. As a consultant here for over 20 years, we never shared the same view about the bed number in the hospital, and I think there's always been this view that we haven't got enough beds from the clinical staff and put too many from the health board. That's the first time I've seen that data start to be unpicked in a way that clinicians will understand. As long as I can remember, we've always had medical outliers, and I wonder if there's something in the continuity of care tipping over from day 7 because you reach a weekend and you hand over to a different team, therefore you start again from the beginning. So there's something about the model of delivery of care. But I think that is really good data, and I think that will help drive something. And then on the mental health side, I'd just like to point out now we're just about to lose our only child and adult psychiatry chair in Wales. So Anita Tapar works in Cwmtâp, but did a lot of work across the borders. We don't have any, and Northern Ireland doesn't have any. Scotland has 4. England has quite a large number. So there's something we need to do around the clinical academic piece in psychiatry and neurodevelopment. And that's probably a multi-health board view that I don't think that should fall on this health board. I think it's a shared responsibility.
Thank you. John.
Thanks, Sharon. Thanks for this ever before. This was presented to us last week, and the mention of the reset week, and I think that was last week. So I'd understand if you haven't got the data or share anything with the board today. But is any initial findings or feedback from the clinicians that came out of last reset?
Yeah, I think in fairness, I understand why we did the reset week. And we touched upon this morning with clinical directors. In some ways, you've really got to plan these things to get their absolute best benefit. And I think it had some benefit. We haven't really seen, there wasn't a massive improvement. In fact, the weekend that took Claire was one of the most difficult ones that we've had. But we have taken a different approach of medicine this week. So we're continuing with a reset focus and calling it an internal critical incident for medicine only. Because I think last week we did a few organisation and we were pulling down other specialties. Well, what do you want me to do? So we're trying to be a bit more focused and targeted. And that was some of the feedback we got this morning from the team. So it had some benefit, but perhaps not as much benefit as we thought. This week does feel a bit better, and we've seen a reduction in the number of medical outliers, and I think it was 40 something this morning. So still a lot that's come down by 2020. And what we want to get to is having these resets or a bit more in advance, and we can't exactly predict when it's going to be on, but we know there are certain times of the year when we could put some kind of break in, some kind of reset. So yeah, we're going to plan the next one just a bit differently and be really, really clear what we want, particularly the consultants, but not just the consultants, about what should to do, because I think that was some of the feedback was, it's great, but actually some people didn't know what the benefit was.
Thank you, Kelly? Yeah, you talk about needing more or less beds. All patients who are in the hospital bed are not using their own bed. To what extent do we ask the question, what is needed to keep this patient at home? What services can we provide at home to avoid them occupying limited hospital beds?
I think that I don't quite know the answer to that. I know the flip side, which is what we're really trying to focus on is, what is keeping you in hospital, and we are encouraging patients to say, what can I go in? What is the plan? I think that's the bit we are grappling with about, well, what is the plan? What are we going to do today that's going to make a difference to this patient? I think, we are seeing, aren't we, so the safe at home is starting to really impair. So actually they are helping us to try and keep patients out. I think as part of the forensic review, we do need to touch upon what is the answer. Because I know we've got variation in concepts. I think there's quite a lot that does happen from a safe at home, and then you've got ED as the next kind of gate for it, and then you've got the acute position. We've managed to get through all of those. Then you kind of, and it's like, well, how do we get you out? So I think there's more to do carrying on.
Good question. David?
Yeah, and just on that point, there's quite a lot of work done in England, which I think you might be aware of, which was some of the physiology of patients in hospital and the reason to reside, with the criteria. And actually, even in the best organisations, about 40% of patients actually didn't have a reason to be in hospital. They're all waiting for things. And that's quite a lot. They're waiting for a scan, they're waiting for something. And that was the finding from there. The other piece of work that was done was the virtual wards in England, which drove up a number of virtual wards just went through the roof. And actually, I think a lot of people who were in the virtual wards could have just been at home rather than in a virtual ward at home, because a virtual ward should actually, as Paul saying, what they need. And Safe at Home, I think, is getting there in providing what we get in hospital at home, rather than safety net, with some more tech around it.
Just to remind me, I mean, waiting for scans, a friend of mine was admitted just to have an MRI scan this week. We've been working with trying to get the scanners down at Kubrick, the MRI scanners to work for the health board, and we still haven't solved the problem. That's been going 3 or 4 years now. So we do have capacity in the system. It's just working out how we use that extra capacity in external sources.
Yeah.
Final comment from Suzanne on this particular section.
Well, just to share with you a patient story, I met a son, a lady that was a patient of ours, and she was in cardiology, and he didn't want to make a complaint, but he wanted to come down. It's just so pertinent to this. So his basic sort of premise was, couldn't get my mum out of hospital. Even though I thought she was well enough, she thought she was well enough. No one would let me take her home, and it's not a prison, you know. But clearly, culture is so significant here. Culture and continuity of care. This was a long bank holiday weekend, and someone somewhere had said the apocryphal words, she needs to see a cardiologist before she goes home. At the end of a long story, there was no evidence that anybody had ever asked or suggested she needed to see a cardiologist before she went home. In fact, in the documents, because the clinical director of the service came and met this gentleman with me, who had only praise of the clinical care and the team, the nurses, but in the notes, it was a clearly documented plan from the specialist heart failure nurse, who had essentially given authority to the plan and the discharge. So, question mark, where did the story come from? And why hadn't the nursing team, I don't want to blame the nursing team, but why hadn't the nursing team who were present on the ward and the resident doctors, why hadn't they identified this plan and then enacted it? Because they'd continued the kind of story that a cardiologist needed to see the patient. And I think that was just a beautiful example of what goes on, probably, we would imagine, multiple times. And it's not that anybody's doing anything deliberately wrong. They're all terribly, you know, I know the nursing staff are way busier than when I was a sister, way busier. They might have 3 different patients in the bed in the same day. That didn't used to happen to me. So, you know, I recognise that, but I think those are the sorts of brilliant stories that this gentleman has agreed. We can use this story. His mum is at home. She's having fantastic care from the community heart failure team. He's delighted and she's doing really well. So it's a lovely story. We should use that maybe David Paul and Emma and Jason to help us articulate some of what we're not quite getting right, because the care was brilliant. But 6 days it took him to get, and even when he said, I'm going to take her home, the response was, well, we'll record that as an unsafe discharge. And the use of that language, why would you say that to somebody who loves their mum? I'm going to say you're right. So, of course, he felt very uncomfortable then and didn't take her home, you know. So I just think if we can use stories, and there'll be others that we should use to help us in the endeavours that you're embarking on with the team, so you know, connect you up.
Thanks, Susan. And thanks again, Paul, for your presentation. You did ask for some feedback on the style of your presentation in the documents now. From my own point of view, I'd echo what Steve just said. It's a much improved format for us as independent members. And I think for the public, being left to interpret information, particularly with graphs alongside comments, just makes it more impactful and more well than human.
Thank you. We should use credit to finance things, because we follow a different format of that.
You see the person that happens to you well. It's certainly a great trend. Colleagues, follow. People and culture is next, Rachel.
Yeah, great. Thank you, everybody. So, as you're all aware, we've got the 3 billion basics around the people and culture elements, but on top of that, we have the enabling actions and the points within the Ministry Advisory Group recommendations. So we continue to really have a great focus on availability of staff and sickness. We have sickness panels throughout the organisation and really looking at all areas, but specifically, around the hotspot areas. The training, as I've said previously, is well established, people are attending and getting really good feedback. So that's done in partnership with our trade union colleagues. I sit here sort of in post after 4 years and looking at the turnover when I came in, and nationally what the turnover for staff was, which could have been up to 16%. And our turnover rate in the organisation is between 7 and 9%, which is a really healthy turnover rate. Specifically around healthcare support workers, where again, that I think Paul and I used to talk about how that area being high, Jason, and now that's within that range as well. So that's a really good outcome there. In the report itself, it goes into a lot of detail, but we've been doing this now for a couple of years, looking at the agency, the overtime, and bank. We are seeing reductions in our medical agency spend and our nursing spend, but specifically now we're a real focus on the bank because we've kind of eradicated overtime where it was used inappropriate actually in the health board. But we're still squeezing, if you see, because we're still pushing to get the best from that and the best sort of prudent care. The team, so I work with David around a medical action plan and programme of work that we've established. And within that, and I know David will always say there's a bigger programme than just job planning, but there is an ask within the enabling actions to get to 90% by the end of September. When the report was pulled, we were at, I think, was it 70, 71? We're actually 75% this week we were. And there is some real low hanging fruit that we can really push now towards that we asked the Assistant Medical Director Health and my team to work with that. So really pushing. And I think even your team was saying that's probably one of the best figures that we've ever had here, but actually across Wales, but we've not sort of become complacent. So we continue with that. We discussed in another committee around that continuation of one paper to look at the workforce and whether that's whole-time equivalent. Susan and I touched base yesterday around the People Culture agenda. And again, so the team are very aware of how we work with our finance colleagues and other colleagues to make sure that we have one paper that goes through the committee. So you've got that sort of single truth paper, isn't it? So, and the same timelines. So we're working towards that. One of our brilliant basics is about the capability of workforce planning. So the team have worked, and I don't know if any of you have explored SharePoint where the training's just come out. It's really intuitive. It's really easy chunked down into the modules. We've worked with HEIW to provide this training for our staff. So we're starting to get a language that hopefully will be cascaded into the organisation. So that's worth a look if you haven't seen it. A widening access agenda. So the team of two look outwards into the organisation. Suzanne and I were invited recently by Amana Cymru to Fitzallen School to look at a work experience conference for our Black, Asian and ethnic minority community, or global majority actually. And it was really great, wasn't it? It was really inspiring. It was actually lovely to see Fitzallen School. They've got a new school that was sponsored by Apple, and it just showed what an infrastructure, if you had a good infrastructure, how behaviours actually had improved with the school children. And that was really interesting concept for us to discuss. Our staff survey is due to commence in October. So my team have been working with Joe's team in the comms department to look at how can we warm up the organisation, because we did improve slightly last year, but obviously we want we want more people to actually participate. So again, there is a communication plan, and we'll bring that into the People and Culture Committee. So I think there's lots of work around leadership and management. I won't repeat myself. There's a couple of programmes that we're looking at regionally to work together to enhance that ultimately regional working. So let's get everybody in the room, that networking, and getting their capability improved. And I think I'll just stop there because there's lots more in the paper. But thank you.
Right.
Yeah, thanks very much, Rachel. Yeah, all this stuff, so again, but to prepare myself, I know you've done some fantastic work, but actually was, in my opinion, a vast improvement on the all I would like to arm myself is reflect back as much as we can on this year's or last year's survey, because they are the questions we get every year, and I was wondering, and I'm not always that could help you know that, but how confident are we that we fed back everything we possibly can to get this year's off to the flying start?
Yeah, it's okay to come back here. So I think there's more sort of the visualization of it, because we've had some staff assemblies that actually Suzanne's been headed up, and the last one that we actually had, we've talked about how can we localize this, because actually seeing probably a similar banding of individuals coming along, perhaps not that diversity that we want to see. So Suzanne said, you know, where we've got local partnership forums, how can we actually bring that alive into the organisation? But I think there is something to do with not necessarily a newsletter, but there's something to visualise what we've actually done, because there is a lot that has happened. And I actually talked to Dawn and Peter in the trade unions around that, whether we could think about how we can sort of help lead that in the workforce partnership group, which Mikey will be involved in.
Yes. I'd be happy to come back to this. Yeah, I did mention last year when we were all of us. So, how can we get the clinical boards themselves involved more? Are we planning to have them more, involved more this year? There's an awful lot they can be touched on their partnership. We now have a leadership board. Oh, it sounds good. You know, so we let it really focus on that and get focused on it now, because something like that, we'll be there, won't we? So I would, not being disrespectful to any clinical board, do need more involvement and more ownership, in my opinion, from the clinical agree. But I think that's the next barrier just to get over.
So I know Suzanne put her hand up as well, but we do have a focus on the staff survey at our senior leadership team meeting. So a couple of weeks ago, everybody gave kind of a feedback of where they were and how they're enacting some of that. We also discussed it at the exec reviews. So there is a slot specifically within the template around that. But I think it's bringing it alive for me, isn't it? That's a template and that's the tick for me. You know, how is it brought alive into the organisation so people are feeling and seeing what we're doing and the actions? That's what people are saying, aren't they? It's all well and good, but where are the actions? So yeah, there's still more and more to do around this.
You also use me as much as you like, sorry, Chair. You use me as much as you like to apologise.
I'm used to it now.
But I got the claims.
We did also talk in years ago, Rachel, about using the staff appraisal process to reinforce A, to encourage people to do the survey, but B, how they found it, how can we help you participate if you don't really participate. So maybe the clinical boards can help a lot with that.
Yeah, no, I mean, I agree, Mike, in the sense that clinical boards need to own this, and I do think they are making a step change there. So as Rachel describes, that there's clear accountability in strategic leadership team meetings. So I asked for their plans, how they're going to get ready for the next one and how they are responding to the last ones. The data goes out. I mean, the data is vast quantities of data and feedback. I see all that data and I send little notes to people going, I've been looking at your data, and we have a little chat. And they probably don't expect me to be looking in detail at their data, but it's helpful because I have not had a bad response. They go, yeah, we know, but we're on it. So maybe it's that visibility. I have suggested, and I know it goes online, that I wonder if maybe either at a corporate and or clinic board letter, we have a Viva Engage page that is just around the staff survey or around team experience or something that gives an opportunity, because we know there's great engagement with that platform. And the last team assembly that we had, which was only 10 days ago, it was really good because the clinical board leadership teams, Mike, they are overwhelmed with demands. But we had one whole clinical leadership board team in the team assembly. They came, not the whole team, but quite, and it was so fantastic to see them there. I was really heartened that the leadership team had taken time out because they'd made it an important thing and they wanted to come and hear, the conversation that was had in the room. So I think I'm always sure we can do more, and I think the local LPF forums, which I haven't been to any of those, and I think we will try and get to some, because I think that feels like a good vehicle, doesn't it? As Rachel has said, to kind of work with you, Southside partners to reinforce this work. And as you rightly say, I know Rachel and the team have got, you know, it's almost, you said we did stuff to get out there, isn't it? Yeah, yeah.
Might also be helpful to talk to Sarah, so that the chance to settle into the literature, where I know a very high response rates to start serving, so maybe this is something to learn from them. Thank you. Okay, I'm going to move us on then. Sorry, Rachel.
Just one thing which is really important, isn't it? We just had our workforce race equality standards through. So just want to note that it's come through because this is important to look at our data around the subject. It's going to come to the next People and Culture committee, so it'll come up to the board. That's just to mention.
Thanks for the.
Yeah.
Okay, my apologies, colleagues. I managed to shuffle the agenda a little bit. So I have to ask you to go back to quality and patient experience.
Thanks, Chair. Take a bit of bread. You can see we had a slight improvement in our performance in our concerns resolved within 30 days to 69%. And we've, as you can see, the data says that we see more concerns than we actually closed. So we continue to monitor that. Main quest point of view, the 342 inquests currently being managed by the organisation, relatively quiet period of time now due to summer holidays in courts, etc. And then we pick up back through September, October, November. We've got a significant number of our inquests being dated for October and November. The civic data is there. Many a time I've said I'm not comfortable with civic data. It just supports the same things. We've got some trials ongoing. We work with the civic team. We're going to do some focused pieces of work and then hopefully start to bring some trends and themes back. So we're going to currently do a patient satisfaction survey on civic just solely for 1 week on nutrition and patient experience of nutrition in the organisation. And I know maternity are looking to do something similar for breastfeeding and compliance with breastfeeding. So hopefully we can start working with the team to start to get the very focused piece of work rather than just bringing the data on how many patients we have reached to on a monthly basis. So we bring that back. Through June, we reported 13 NIs, national reportable incidents. And the themes are well versed around deteriorating patients, loss of follow-up, medication safety issues, and in the organisation. And as you know, all of those themes are picked up in our quality excellence programme, where we start to utilise quality improvement methodology to work through those and to improve and transform some of those areas in the organisation. So hopefully we'll see that piece of work. The project groups, each project group as well, and truly embedded now, and we're seeing some really good stuff coming from that. It's touching wood, but I'm pleased to announce that we've not reported a never event for the last 3 months, which is a good position to be in also. The incidents there, as you can see, open over 30 days at 2,725. We monitor those on a monthly basis on quality executive briefings. And I know that there's the corporate teams have devised a programme over the next 12 months where they go into the clinic to support those teams, start to influence some of these incidents down there. We are starting to see a slight, but we are seeing a downward trend. Our IPC data is there for you to view, and whilst all the bacteremias are tracking where we've been in the last 2 and 3 years, they're not at the reduction expectations that are set by Welsh Government. So obviously we've got a continued piece of work to do that. And as you know, IPC is a big project that sits under quality, it sits within quality excellence programme. CDIF, we don't have to say here, we're on to a reasonably good start from the CDIF point of view, far better than we started the year last year at. And we continue to monitor that. So hopefully lots of things that we put in place are going to support that improvement through the year. MRSA is a concern currently because we've started the year higher than when we started the last couple of years. And again, it's back to basics, quality excellence programme, and hopefully we do some really good steps to try and bring that down. I thought I would give you some positive news, not in my report, but because what wasn't ready for the report the next time of the report. But from an organisational point of view, our news tool, which is our early warning score, it's phase 2, which is the approved news, has gone live across the organisation this Monday just gone. So obviously we're watching that position very carefully. Main main difference is that the escalation to, the nurses to escalate to medical staff and the party is lower at score 7 instead of score 9. So we see more people being escalated for medical attention and specialist attention. Hopefully better patients because we catch them earlier and hopefully be able to treat them before they deteriorate. Staying on that theme, our news for our neonatal is fully implemented in the neonatal unit, and that's really well, and we're looking at it to see how that's going. Paediatric early warning scores as a theme, nationally we've updated all the early warning scores. So from a paediatric early warning score point of view, that's live in September, and there's lots of training ongoing with that. And from a news, which is return to early warning score, I'm pleased to announce the BadgerNet went live on Monday. I know that's probably David's report about BadgerNet is the new digital maternity service system. Lots and lots of benefits, digital recording of notes. Therefore, then we'll be able to see instantly across Wales, a numbers transferred down the notes from another organisation when they finally get the BadgerNet. And then, of course, our early warning score will be plugged in. So we leave a BadgerNet setting first for people to get used to the digital recording because it's new to them. And then we intend to plug in the early warning score, digital early warning score, in September. Big thanks to David and his team. I think there's been digital people this week and leading up to Monday, as many digital people as live right on the north. I think, and they've been there for the same number of hours. So a big thank you for that support, and it's gone moving really well, and I've not had any issues reported this week, and the technology's worked and it hasn't gone down once, which is always good. And our sepsis, last of all, the other good story is our sepsis screening tool. There's always lots of focus on sepsis in organisations and patient safety. Our sepsis screening tool has gone live through January, July, last 8 days, so it's in all areas of updated sepsis, which we're linking with it when you're doing analysis. So, good. It's a good step up.
Thank you, Jason. Anything to add, David?
The only bit I think which we did the report, which just to draw your attention to, is one of the themes the medical examiners drawn out is the application of Mental Capacity Act. And actually, we started to do some work on that and actually look at the compliance in mandatory training around that. There are sections that are not compliant with that. One of them is the medical workforce. We've got a meeting on Tuesday. David Scott Coombs has been leading a piece and looking at the mandatory training in the medical workforce. There's a big meeting on Tuesday where we're going through it and addressing this.
Thank you, David. Any questions or observations for Jason or David? Suzanne?
Thank you very much for the report. On the NRIs, the report speaks to, we're operating in a rate in line with the national average. But I would dispute that and say, I would say, well, we don't want to be in line with the national average, one, and two, we're higher than the national average. So just praising of the position. But I did wonder if because I like the middle chart very much. I think that's really helpful. I don't like the shape of it, I don't like the direction of it, but I think having that time between incidents reported like that is really good, Jason. So I think now whether or not we want to set a trajectory of that, maybe something in the future. But I did wonder if we wanted to have a chart with the never events on, that we can see that data, because I can't see it either. And I think that one, colleagues might get muddled between them and they're not the same, and two, it'd be good to see those never events coming down if the same.
Yes, that's why I discussed them. So I said we had 13. I'm going to bring probably more granular detail on the net on the national NRIs, so that you get a feeling.
Brilliant story around the news and the early warning score implementation. And I was just wondering, with the paediatric one, will that help us be confirmed with Marcus law? Does it include a kind of, if the family raise an issue, it's an automatic escalation? Or
so I suppose two things. The POs won't, because we've already got an early warning score where you do observations on a child, you saw, and then the sort of donate Stephen whether there's an escalation. Don't forget, we've got of concern, which we fully embedded in the organisation now, which is there for Martha's law. So if any relative has got a concern, whether at home or patient late sitting in the bed, laying in the bed, they can phone the court concern, and it goes directly to our party team or party triage, and then we'll end up going.
Some data around the utilisation of that or the impact would be something.
Yeah.
Thank you, Suzanne. Can I reinforce Suzanne's point as well? I don't agree at all that we're in line with the national average. There are a whole incident of which is not where we want to be. But can I also pick up on NRIs, Jason? You said we've got 13 in June. The graph I'm looking at here looks as if we've got just under 4 for June, and maybe misreading the graph. The concern I've got is we are getting consistently high numbers of NRIs month on month. We had 10 in April. We had a little bit in May. We had about 13 in June. We don't appear to be making progress in terms of learning how to avoid these NRIs occurring in the first place. How are we dealing with that?
I suppose there's two things. There's the organisations this size, this complex, will see a high level of NRIs approachment. We report them when we first are aware, given the criteria of potential harm. We often set those down then following the investigation. So I think it's good that we report MRIs because it's an open, transparent culture and people feel safe to report. Because some of these MRIs are very, very complex and can lead to significant harm. So the meaning by the fact that we've got people who hold their hands up to say, I've done this, this is a good thing. And I think it goes back to the psychological safety of an organisation. What you don't see here is that often the NRIs step down. So this is just what 13 in the month. We may very well just sort of report it 4 by the time we've investigated them and then close them back down to Welsh Government. Because we report them initially to Welsh Government, so there's no surprise to Welsh Government. And then through the course of the investigation, we go back to Welsh Government and we have a conversation and we withdraw the NRI. So often our final numbers are
I think we need some clarity around that for the board, Jason. I find that quite confusing. Eric?
Yeah, and there was a deep dive of what was mentioned earlier, quality committee to determine where common factors work, and obviously the use of the World Organization checklist is a factor which affected the theatres review as well. So there is ongoing work and learning from reportable incidents, which hopefully will manifest themselves then in improved performance.
Thank you, Gary. But can we illustrate it in a different format that these are us as independent board members perhaps and for the public interpretation? I think that would be very helpful. Further questions? David?
It was just, I don't know if you picked up that the graph, it's a rate to 100,000, so that might be one of yours.
I thought I would interpret that incorrect, but they didn't say. Okay. Thank you, Jason, and thank you, David. We'll move on then to digital. David?
So the main KPIs are in the actual report, but just a couple of things I made to call out. So this is the Foundations programme, which is our strategic plan, if you like, for digital. We are nearing completion of that programme business case now, having run more than 40 workshops with staff across the entire health boards. So lots of engagement from clinical boards and clinicians in terms of what that programme business case needs to be achieving. That will now need to go through the internal governance process. We're coming back to board here, I imagine, in November, with us going through the other internal groups and subcommittees. We're also talking to Welsh Government, keeping conversation live with them in terms of an expectation of an ask from major capital for next year in order to fund some of the requirements as a result of us working up those business justification cases. I want to say something about EPMA that's been said, digital services has been said. The Welsh Nursing Care Record, that's now across all of the wards as well, Jason, so it's another digital tool that nurses can use. So lots of good news stories there. There are lots of other national programmes that we are supporting, things like LIMD and radiology, which we'll probably go into more detail in the digital committee, but there are some challenges with achieving those deadlines. There's lots of work to be done, but we are working through that. The Connecting Care programme, which is the replacement for what was the Welsh community system, which we didn't use in Cardiff and Vale, but the Vale of Glamorgan have been using. There's a programme being pulled together to replace that. Given that our power system is in need of replacement, we are working with that programme now in order to make the case, if you like, for funding to replace that. The outsourced work Paul referred to is a project that we are urgently doing, which is to make sure that people have got the right passwords and access to all the IT systems for when there are people coming in on weekends who may not normally have access to those systems. So that's happening in readiness for going live on that. That's probably all I'm going to say at this stage.
Any questions, information? Okay, thank you very much, David. Are we all happy to note the integrated performance report? Thank you very much indeed. I think what we're trying to do is shuffle the agenda a wee bit today. We'll deal with item 6.11 on the agenda, the annual plan 41 update, and we'll break a bit early for lunch and convene. So I can see that we're all getting a little bit more and perhaps flagging in the evening. So that might be an easier way. So, Catherine, can I ask you to run us through the annual plan 41 update?
Yeah. So this is the annual plan update. This is a reformatting report. So any feedback would be gratefully received about how we can make it flow better, and linking to the paper that we took before the IPR. So it would be really good to see all of the levels of which we need to work at and how we move this on a way that connects together and makes sense for people, while also giving enough detail and assurance that we're going to deliver. The start of this report is focused on this year's plan was around getting back to the basics and doing the basics well, and we've heard lots of that in the meeting today and in some significant detail. The table on page 1 here were the strategic priorities in year 1. So these were the things, if we did nothing else, we wanted to do to make sure we were moving forward with our strategy. The section below just gives you an update on where we are with those elements. And you can, you know from the meeting so far that we've updated on many of those during the course of the meeting. So how we leave this together, so you can see where we are. There's a brief update on the finance, which we've already discussed, and also the key delivery expectations. So these were before we received the most recent letter. I thought we're going to these were the minister's key delivery priorities, which we together. Some of the things that are in the letter. You can see there, and you know that we've updated on trying to do the operational ones there, as well as some of the other ones. So then in terms of where we are during the course of this year, this is the first year we've blended the strategic delivery with the annual plan delivery. So that's probably the thing that's a bit more bespoke to you. And in terms of the strategic delivery, I think where concepts were developed and worked up as part of the plan in September to March period, we've probably hit the ground running, and we're making good progress with those plans at this point. Yeah. Where ideas were more conceptual and needed a bit more development, I think we're still on the development journey, still scoping the projects and still trying to work out how we get to implement some of those things. And if you think about it, maybe the outpatient transformation is in the latter box, and some of the 104 week and 52 week is in the former box. So you can see that playing through here. And bearing in mind we're only at page 1, I think that's a reasonable place to be at this stage of the year. But we need to be cognizant of what then mean for delivery of the plan. And that's the bit I think that's still in development here. So there are some very specific measurable, yes, this is a bit of nepotism, but there are some more intangibles in there. And so I think our piece of work to do now is be specific about what are the benefits of delivering this action and how will it allow us to then move to the next step. It may be a very, very tangible delivery in this year. It may be that, but by doing a piece of scoping work or project work will allow us to then get ready for the next step on the strategic pathway, which is an important thing that we need to deliver. So it's more preparation activities or enabling activities. I'll stop there, take any queries or questions and feedback that occurs to people having seen it for the first time. This has been gone through is the business of the whole board and how we get to online as well as
Thank you, Karen. Any questions?
Yeah, it's really helpful summary. So thank you. I just had a specific question on workforce planning. Really, you know, it's kind of tied into so many things, and I guess generally, you know, without starting from a running start in terms of there's a focus here on certain those areas, but we also talked about national claims level workforce planning. It's integrated system. I'm just wondering, you know, where this is going to be going with, because it's so fundamental that a number of other areas, and Rachel feels this kind of the ability to develop this capacity and this working across educators, providers, so on.
Yeah, so our workforce capability around workforce planning is not good. So we have, when you talk about strategic workforce planning, you know, you're looking at a 5-year horizon. You're not good at looking at 3 or 1 to 2. So that's where we've started with using that training, working with HIW, because there are the workforce plans that come out. So we are concentrating on the mental health one specifically with the team at the moment. But I think it is really chunking it down actually, because otherwise it's so daunting. People think, oh gosh, you know, I can't do it. But last commissioning of our education numbers was so much more robust. The report we put in and worked with the clinicians, and now how we monitor that, because what we're seeing is our modelling is changing as well. So it was about 3 years ago, Jason, we might have had a gap of 400 nurses, and that's now we've filled, you know, we've got a surplus of nurses in the whole system of Wales. So I think using HIW's modelling data, looking at a sort of a 12-month, 2-year, 5-year, and taking it down that way, that's sort of our ambition with a small team to work with Paul and the clinical boards as well. It's really important. I mean, you know, if you look at the data around workforce supply, you know, we're getting close to that. The workforce supply is actually going to be diminished because of the aging population and less births, etc. So there's a lot of assumptions that we're now bringing in and scenario based around workforce planning, but loads more to do, Sarah.
Thanks, Rachel. Thanks, Sarah. Good.
Thank you, Catherine. Just in terms of the 41 performance summary chart, I'm struggling to understand what the data captured in that chart means. So I can see that some of the data has got red dots against it, some's got green, some's got nothing. Some of the data appears to be for the quarter, some's for May, some's for June. If that just be looked at again, just to make that a little bit clearer, so we understand why there's red dots, why there's green dots. Also, so that there's a bit more explanation about why the data is being presented to us in different ways for different months. It's just not entirely clear for me, personally, looking at that, where we're definitely on target and where we're possibly.
Thanks, Houston. Any other comment? We start always difficult to monitor success. An annual plan for efficiency of score. It's a good story. Okay, we're happy to note the progress being made. Thanks very much. Okay, it's just 12:30 now. Shall we just take a break for lunch? A little bit of an even plan. If we can get back by just after 1 o'clock, please. I'll call 1 o'clock. First of all, welcome back, everybody. We're moving through the agenda now on to item 6.13, which is the theatre services review. Paul, if you can lead us on this.
Yes, thank you, Chair. So board members will recall we had quite a detailed conversation back in May following the publication of the service review of theatres. And back in May, we talked about the immediate actions around the 6 key recommendations. Gave a commitment to come back at the end of this month with an update on progress. So what the cover paper is explaining is where we've got to on the sort of immediate actions and the high impact actions. Just to be really clear as well, we've also got all of the 66 recommendations now into one place as an improvement plan, which we are going to submit to the Cabinet Secretary Laura and to HOW. Just didn't have it ready in time to submit with these board papers. It's quite a fluid dynamic paper. But I agree with the chair that we also played that all board members are. What you'll see on there is all the 66 actions. Of course, some of them we've listed, but we haven't started to address them yet. And this is likely to take a 2-year program. So you'll see the complete improvement plan in the next 24 hours. But today, this is more about where did we get to with what we said with the initial actions. The foundation put some tranches, so the foundation tranche and the higher action. I think what I would say, I'd like to massive recognition really to the effort from the team, because taking those 66 recommendations and starting to work out what we're going to do with them is quite an undertaking. And you'll see that we've already made some significant progress at a time when we've had some uncertainty about the leadership arrangements within theatre. They've got the day-to-day responsibility of trying to make sure the theatre is run, etc. So I think they're making really good progress. They're probably a little bit harder on themselves than they need to be. I think they could have made more progress. But I'm hoping the board would agree that you can see that we've set out a programme of work and we are making progress against it. So then the other thing to probably say, and I talked to Chair about this briefly this morning, is that we are also picking up other things as we go along, and I think one of our challenges is to manage this programme that it doesn't become there is too much creep. There are some things that are inevitable. So I'll give you an example. The female changing room is cited as an action. We've actually expanded that to the security of the overall theatre suite. So it's moved from just sorting out the changing rooms to making sure that we in the access, about three different access entry and exit points in main theatres been addressed. That feels totally appropriate, etc. Some of the other actions, for example, so we talked about the anaesthetic room, we standardised, making sure that the documentation is standardised. That's been done. The danger is that then becomes bigger and that we need to refurbish everything and we need to spend millions of pounds. So we are managing this, in a way that we attend to the recommendations. We pick up the things that absolutely we found that must be addressed, and then we talk about some of the other things and how we might attend them. So we go from the business, for example. You never expected that we would spend millions of pounds of capital that we don't have. Nonetheless, there's an opportunity to talk to the government about the way to improve our facility. So I hope that makes sense. I'm happy to take any questions, give you any detail, but I think that the improvement plan is pretty straightforward, and the overview kind of just gives a progress update.
Thank you, Paul. And before I open it up, could I ask you to pass on my thanks for the gratitude of the board to your team for reducing this work stops, but importantly to the theatres team for their willingness to share with us by following up, by collaborating and trying to get things right. So I think we've all understood here the significance of what was uncovered. And don't forget, everybody, we uncovered this through our survey and genuine interest in the well-being of our staff and our patients. What we hadn't appreciated is the number of areas that needed attention that we now do, and we're addressing it. I think I'd like to commend our executive team for having that open-mindedness and honest approach to look at these areas and tackle them with collaboration of the staff and doing it for the best interest of our patients. So thank you for that, Paul, and please pass on my thanks. Okay, any questions, Paul?
I guess I was just wondering what the feedback of the team is. How are they feeling now, and how will we know? I suppose I know we've all spoken to them individually. I'm thinking less of the leadership team who we all interact with regularly, but more some of the frontline team. I've certainly had some interactions which have largely been really positive, but I wondered probably how it feels and how we're going to know.
Yeah, no, thanks, Suzanne. I think this question came up my last week in the question. So, so I think at the moment, well, what we said we needed to do was to do some of the kind of open briefing sessions again, probably in September. But we're in that kind of in the season at the moment where, which is why the theatre start team have probably been a little bit harder than themselves than I would be. Things have to slow down a bit, annual leave, etc. So we are going to sense check with the team, the theatre team. Are you getting the engagement? Are you as included, as involved as we promised you would be? And I think that would give us an indication. We could run, and I'd probably take Rachel's advice on this. We could run another kind of pulse survey or something at some point, but it's been made. You need a little bit of dust settled.
Yeah.
You need to get the improvement plan in order, so we know what we're tackling. But we gave that commitment; it was to be co-produced, and I think we do need to test. We said we'd do that in September, just to sense check that we are all still going in the right direction.
I wonder if it's worth just making that addition somewhere to the plan.
Okay.
Just if we're going to do one, or there's something about building in that feedback loop somehow, isn't there?
I think that's a good idea, Suzanne, if you don't mind me saying. And also for reflecting perhaps in the documentation the fact that you've gone further than the recommendation, found it necessary to expand the work.
Yes, I think it's a good idea, but I think there's some things that we can do sort of culturally before. So linking in with the WHO checklist, we can do about role clarity. There's different interventions, small interventions that we can do just to get that clarity of what they're doing, who's in charge of theatres, blah, blah, blah. And then I think we should then do another survey just to see how we're progressing.
People, can I just ask that it's really good to hear about the progress that's being made, and that there's a clear plan in place to improve recommendations. Are there any that you're concerned about in terms of compliance?
No, not just the time to do it, I suppose. We've got to be ambitious, but we've got to be realistic. So there's nothing in that list really. There's 66 of everything we can't do that. I suppose it's just managing, as I was trying to maybe I was alluding to, managing people's expectations around need to standardise the anaesthetic rooms to have that means you're going to refurbish completely and it's going to cost us £100,000. So I think this is some similar kind of conversation with the cleaning schedule. So I think managing expectations and keeping to the spirit of the recommendation is important. It will just be the momentum. Perhaps to Suzanne's point, we've got to get through the summer period, but to make sure we've got the momentum to do the right thing and continue the enthusiasm that the staff gave us when the report was published. So that's probably the thing that if I had any concerns, and I don't at the moment, they would be the things that I would think, okay, we have to make sure we've got momentum. And the people aren't expecting a brand new this complex because we know the problems.
Just, yeah, thank you. That's really good to hear that. And I remember when we first started to look at this issue, one of the things that was recognised was the impact on wider teams around the theatres team across the site, really. So just wondering whether or not you were seeing any of that. I'm thinking specifically, as you're spending money in this area, improving things that absolutely have to be prioritised and improved. Is there then a sense elsewhere, you know, why is that happening there, why is it happening here? All of those issues, how is it generally affecting workforce?
Just to be clear, we haven't spent any money anyway yet. We haven't spent any money yet. And if we do spend any money, it'll be because Welsh Government have given us some money for an absolute pressing need. So there's always that kind of slight tension we have sometimes about why that department, why not us. But we haven't had any of that yet. So I think people recognise there's an issue that needs to be addressed and have been very supportive of the direction of travel. Now, even if it comes down to it and we start to maybe it's we'll manage that.
It's just watching about behaviours as well, isn't it? And that psychological safety aspect. So I think thinking in with Matt and speaking of safety element, are other things coming through? Are we getting, because all of those measures that we were picking up in isolation, I suppose, we bring them all together. So I suppose it's just watching with the WHO checklist, everybody you've written out, but actually do behaviours slip back and who's going to call it out if that does happen? So it's that measurable. So it's quite hard sometimes, isn't it? So working on that.
Yeah, I mean, I suppose what I would want to just remind Saul is that about 3 months in, there's probably a 2-year improvement, and so we won't have changed all these behaviours overnight.
Yeah.
And we've got to build that capability in the leadership team as well, which has still got some gaps. And so sometimes we might go a little bit backwards, we might not quite get, but we just got to keep going. So, you know, it's early days. Imagine that, you know, some people are feeling a bit, well, they should do this, I haven't done it yet. That's the leadership challenge, really, is the motivation going. But I suppose, you know, there are still other things that are happening that affect people. So the sentencing this week, the next number of stuff, that will have been happening around. Almost concluded the investigation. There's still a few bits of unfinished business with things that are still rippling. We just need to wear it.
I think as well that there's probably safety net and call it that. We've been closely working with health improvement willingness. So they're obviously going to visit at some point. So as a board, we'll probably get some further assurance, I like to think, from their visit and what they find. If we're not on track, you know, we have to adjust something. It's sort of a safety net. My choice of phrase, I think.
You made a really interesting point about can we and what are the measures we can look at over time to give us some assurance that this fantastic collection of activities, focus and support is making a difference. So I do go back to some of the work that we looked at, you know, the reading signals right up here, and I do wonder whether we should establish some kind, whether it's specific to this piece of work, sort of dashboard that would include WHO safety checklist, compliance, or staff survey, you know, combination of measures that we say, these are the measures we'd expect over time to improve. We start measuring them and we can identify attributability to the actions we're taking. Or whether we actually need to do that piece of work more broadly as an organisation, a kind of waterfall set of measures. I'm not really sure myself yet, but I think we do need to think about it, because clearly some of these things will have very specific measures. So, you know, who safety checklist compliance is a point. and we need to work out what we're going to measure to give that assurance, because what we know is we won't get an assurance despite the measure, so that isn't very helpful, is it? But I do wonder if there's something in the mix and we should think about anyway, going to the next phase to kind of bring as a board dashboard, and whether or not we wrap this a similar kind of dashboard around different areas that we're doing this kind of work in, or they need to be bespoke. I don't know, maybe David and Jason and Emma look at with Claire at some of the evidence base in other places. What do you think, Paul?
Yeah, I mean, we'll have a collection, I suppose, getting it all in the right place at the open, isn't it? There'll be some things that are fairly obvious, rates and sickness rates, and BVA compliance, and but it is some of that signal, that heat map. I say, well, what else? You know, is the other complaints going on, others, NRIs.
That's the trend. Those data points. Maybe we will miss it. You know, that's worthy of thought.
Sarah?
I mean, I think that's would be external sources of information as well. It's also about leadership. Leadership and so to say this is a problem. I need some support in dealing with it. So there's something about that confidence. Getting the right leadership.
I think for colleagues, you know, we will have to return updates to the secretary and so the board will need that site. We'll have regular monitoring. Big country issues, magical, government, human, investment. Okay, any other further comments, observations? Thank you again, Paul, for presenting the paper, and thanks to your colleagues and the other colleagues for doing. That's note. Thank you very much. Move on then to items for approval, section 7. First one is 7.1, business case for transforming access to NIDS. Issue.
Just check that it's in the order. Okay, that's fine. Yeah, sorry. That's fine. So this is the business case for transforming access to medicines. As we know through some of the issues we've had that our radio pharmacy provision has been reducing. We're unable to provide the medicines that we need on our sites because of the state of our thing. And we have those down, at least one of them, and the other is pretty on in some areas being our best facility, but there is many more compliant than the other. So the trans business case was it's developed by Shared Services and run on behalf of South East, but not just even this, the South East for their needs, which serves us. They provide diagnosis and operation surgery, and it hematology and other clinical indications, and it provides for Lindra, and it provides them on behalf of the health boards in the South East region. This business case is coming to us today to secure the capital funding. The revenue is to be within the existing revenue that is available in South East Wales. You see that there are savings highlighted in the case, but in addition to the savings highlighted in the case, there are some areas that haven't yet been resolved. One around TUPE transfer flying, which is going to be very important for us, and Lindra as major employers of the individuals. Even that's a debate that's managing now, but our position would be that TUPE transfer does apply for the individuals and also for the safeguarding of the skills in order to do the activities
which are by nature very specialist. There are two other areas that we need to resolve as part of this, and they feed into the final full business case. One is the service provision. There are certain parts of the service provision that we provide at the moment, or Belinda provides at the moment, that are not replicated in this the trials is one of them, but there are some small services which currently at the moment are orphaned and don't, which would mean that someone will have to provide those services until such, and that's not included. So there's some negotiation happening between the and shared services. Some of that is because building that's been selected and the infrastructure that's around the buildings is selected is not suitable to do that. So it does mean that there's a bit of a service swap around that needs to happen and needs to be negotiated, which is underway but not concluded. But we do not want to be held with a legacy cost or the infrastructure that we cannot raise. And in terms of staffing and efficiency, both ourselves, Linda and other health boards to an extent, need a receipt and distribution and a logistics arm that sits around this, and that currently is not covered in the case. So that will erode the savings because we cannot ignore that infrastructure. So those are the things that aren't done. So cases here, the capital is a priority for Welsh Government on their list of things for this year. I commend it to you, recognising this as well. The commitment from shared services is these things will be resolved prior to that.
Thank you very much. Any questions? Just
do we have any idea of timescales yet? And that might be when this will actually take place. In 2 years, 3 years.
I think it's probably in the 18 months sort of time sphere. There is some cracking expense that's been done. Securing the capital is why the case is coming. This certainties in it, but securing that press through to this cases is almost all of its own and to manage the time scales.
I'm pleased just for that. When we do approach or to finance to start is to be employment and confidently we may be able to swap forms to make sure that the transfer goes that when we go into those transfer, we involve trade unions from everyone. After the transfer, and make sure that you you had to transfers into the situation where trade union actually listen just people can ask problems elsewhere. So it'd be really good if we can connect with trade unions in those areas to avoid regulations to make everyone a lot easier for labor.
I think we need to resolve the service delivery to solve the staff and the expertise, and then what's legacy. Yes, yeah, and that will then clear that. But I think prepping the way, I'm looking to raise.
Yeah, Ali, the DP, the business partner within CBT, is really tight to this. It might, so she's very aware of and actually highlighted some of the risks. So, yeah.
Thank you, Mike. David?
Yeah, it was just thank you, Chair, and thank you, Catherine. And this is one of those areas that every time I'm looking at it, it becomes a bit more complicated. And actually, the clinical trials bit is, I think we need to really be clear about what the risks are involved in that, because there's quite a lot of risk in what's sorting that and delivering that. I think it's moving forward now that it looks like we're going to start collaborating a bit more closely with Belinda to actually come up with a plan that fits all the needs. And it's linked to other bits as well. So it's linked to the research strategy going forward, it's linked to genomics, it's linked to the advanced therapies. It's a really integral, really important part for strategy of the organisation going forward. Associated with this is all the other bits of the infrastructure that they need to have on that delivery. So I think probably got to make sure that we've got this identified in the risk register probably a bit more clearly than it is.
I think you're absolutely right, David. I mean, we're going to end up with 2 compliant units, one which hasn't been built yet, and one that will be in the new Berlin Cancer Centre. And then we'll have St Mary's, which will be only about 20% full. Isn't very good now. So we do need to close St Mary's, and we need to provide everything that we currently provide out of a compliant unit. And that's the piece of work we're doing now. And there are infrastructure issues with the site that's been picked for this, which means that in spite of shared services, they're not going to be able to resolve particularly those very complex trial things for us. So we do need another solution, which is not St Mary's.
John, I think this business case was channeled through the Finance and Performance Committee last week. As chair of that committee, can you give the board some guidance on the findings?
Yeah, the points that Catherine was giving us we'll discuss that some performance, and I'll have a good discussion and question. The decision was to recommend for the move to OBC with a clear understanding these issues would be resolved for the front business team.
Okay, with that in mind, colleagues, are we happy to approve the attached transforming access to medicines case, an outline business case, as Catherine has emphasised to us in our efforts to try and secure the capital, and noting that the required actions prior to the business case. Happy to do that? Thank you very much. Thank you, Catherine. We'll go on now then to 7.2, which is the digital transformation review or self-assessment. David.
Thanks very much, Chair. Essentially, Audit Wales is carrying out a review of digital transformation across all NHS Wales bodies, they all have boards and other NHS organisations, to understand whether organisations in Wales put the necessary arrangements in place to support digital transformation. They cite things like enhancing patient care, improving efficiency, driving innovation, sort of things that we are including in our digital strategy anyway. There are a number of ways in which they are assessing us. One of them is to seek the completion of the self-assessment shared with some weeks ago. And apologies for the fairly tight time scale for getting that back, where it's something for a holiday. Nonetheless, we did have 10 responses back, probably sufficient to be able to submit. Within the paper, I summarised what the responses were telling us, and in Appendix 1, action paper, there's a detailed explanation of who had agreed or disagreed. It's all anonymous. And at the end of that appendix, I've done a summary of where I think the messaging is, if you like. So the purpose of this today is to ask the board, do they agree with what has been done as a fair assessment? And then have a very brief discussion.
Thank you, David. Thanks very much indeed. Thank you for listening in. And thanks, colleagues, for those of you who did take part in the survey. It was quite a long one, quite detailed. So thanks very much for your contribution. Any observations or questions for David? David?
Yeah, I read through it, and it's just a bit of a mixed picture. And some of the comments are interesting. And obviously some board members are going to be a lot closer to this than others. But I was up with the question, okay, well, so what happens next? And obviously there's going to be a Orwell's report on this, which will be interesting from a benchmarking perspective. But I think what will be interesting, and no doubt we'll be discussing it at DHIC, is okay, so what are we going to do now we've got this feedback?
Yes, thank you. I think you're absolutely right, David, that not all the board members will be incited in some of the detail in here. I think broadly speaking, I think everyone's unanimous that people are all supportive of the digital transformation. I mean, the main block or the main challenge we've got, I suppose, is the investment. We haven't necessarily addressed things, but we are looking at ways of addressing that. I fully expect us to be able to compare with other organisations to see where we're at. And this will tie into Welsh Government needing or wanting to develop a national case, if you like, for electronic health records. I think that Digital Foundations piece fits really neatly into that. There are a couple of things which it picks out where I know we're not mature, and that's around AI in particular. So that I've had a conversation around how we might be able to address that. But on balance, I wasn't surprised by the findings, having gone through them all in some detail. I think it will give some assurance. It may ask some questions, but I think from all Wales perspective, I expect us to not be an outlier in any shape or form.
Yeah, as I was going through the very, very long survey, it gave me a lot of time to reflect. And I think, well, my reflections were we often seem to duplicate the reforms that we've already seen at committee. Finance reform, the classic case, the business case is true. We've often had a chance to scrutinise on how assurance at committee level. I know we've got a digital infrastructure committee, but I don't think we see the same amount of duplication, the same amount of flow from the content of that committee and board and others. I think we are getting a lot better at it by virtue of the inclusion of digital in our monthly performance review document. I think that's really, really important. What I would like to see is that I am conscious that we have a digital strategy, but in the same way that we're getting a lot sharper at reviewing our progress against, we've been talking about that this morning, maybe whether we can have quarterly, 6 monthly check-ins on how we are doing against digital strategy, perhaps in a more overt way at board development. I think that would give us that assurance. You know, we know what's happening, but having those kind of check-ins to remind us.
Yeah, thanks. Yeah, one of the things I've talked to David about is maybe having an annual or maybe biannual deep dive into digital in its broader sense, what it is we're trying to achieve, how we're supporting the organisation, how we're supporting the service lines within the organisation. It's fairly broad, but I think we could do some targeted sessions through a deep dive probably, and bringing the board up to a level of knowledge that probably exists more in the committee. And it's difficult, isn't it, to bring things from a committee in sufficient detail to give that assurance. But that's the trick.
I think on the back of what Ryan's suggesting, maybe some key performance indicators could be drawn up to be able to monitor, understand what progress we're making against those.
Yeah, and if I based on the other point, some of the questions alluded to what's happening outside our organisation as well. We know the challenges that we face in terms of aging, obsolescence, AI, introduction of AI, and so on. I'm not unique to this Cardiff and Vale. So it would be really interesting to understand on a national level. You know, we've got DHIC. I would benefit listening to understand a little bit more about what DHIC is doing in this space and what other health boards are doing to address all at the same time themselves. So maybe a little bit more of an external context of what
Yeah, there's a national peer group, digital directors. So we share a lot of information. Some of that gets fed into the digital infrastructure committee, but I think maybe giving a bit of a national picture on things. And as I say, some of this will help us benchmark in terms of where we're at as well.
It's probably quite timely regarding the workforce element, and David and I are working on this. is the refresh of the People and Culture Plan this year, and it's part of our first portfolio discussion. And I think there is a part about digital there, but I think in the last few years we probably haven't strengthened that as much because we've been focusing on other components. I think now, and hopefully within the plan, we can kind of bring it together so they're not all in isolation. So yeah, I'm quite looking forward to that digital element really lifting up for the people, their skill set.
And there's a huge overlap there in terms of competence and confidence in the system for us people to use. We know that digital maturity is also digital literacy is a challenge.
I think as well, really, in terms of engaging and understanding what's going on in the digital health infrastructure. It's not an exclusive club, colleagues, and if you have the time and the information, you can attend these meetings. It's not designed as a block operating. Susan?
Yeah, thank you. For me, working through, because I was one of the respondents, if you see responses coming back saying, I don't feel like I have enough information to know, I own those comments. And so for me, there's the most crucial really, because if the purpose of the audit is to ascertain, does the health board have the necessary arrangements in place to support and embed effective and safe digital transformation? I'm not convinced that the outcome of this survey gives us that information. What this survey gives us, I think, is an indication of our knowledge as individual board members, which may not be an accurate reflection of the actual position that the organisation is in. And for me, there's a really important differential, because if you just look at my responses, you think Cardiff and Vale might not be in a very good place in relation to this. And I'm sure we're in a much better position than my responses indicate, because I simply don't have the depth of knowledge around the detail of the questionnaire to be able to provide an accurate response. So I think it would be really helpful to guide us with that differential. Perhaps that comes through committee. But where the indication is from the findings in this survey that we may not necessarily be in a very strong position in that area, that'd be wrong. It's just that we as individual board members don't understand the details. So for me personally, I'm a member of that committee. It would be really helpful to have the analysis of the survey put in context of the actuality in terms of where the organisation is, so we understand whether or not there's a difference.
Absolutely agree with you that. This is only part of the overall assessment that all they'll be doing. So they're asking about the documentation after the interviews with other key people, myself included as well. But, yeah, I fully take your point. There'll be a rounded view of what the board understands in the corporation, the art of that.
The thing with you, I this as well, and I just didn't know that. But I wonder whether it would be helpful to read some of the things that the other papers that we get. So when we get business cases, we get service transformation plans and so on. There's something in there around the role that IT and AI might be playing, so that it doesn't have to just sit within that committee, because it's all about context, isn't it? And how we move to digitally enabled, and we do that, and so on. And it was hinted at in the transcripts, so it's a really important part of it. So I don't know whether there's something about making that transition to being more literate and more focused on the rightful place of digital as an enabler, that might start to see that written.
Reality of digital will affect everything we're doing. So how much we put our attention to in one place more than the other. But yeah, I think you make a very valid point. Yeah. We do need to understand where digital plays a role in everything that we're trying to do. Maybe we need to be more upfront about that.
It's a thought.
Yeah.
Further question?
And I'm interested, Dave, in what they're going to use this information for. So I think it's good. It's good to hear that there's a rounded, that there's other component parts of the assessment, because, are they going to use the information to inform their preparatory phase for deployment of the EHCR? Are they going to decide who goes first and who goes last? Because, X organisation needs more preparatory time. What is this for? Because the stated aim is a bit loose and vanilla, isn't it? So I do. That's what's been going on in my head. What are they going to use this information for? This is not for us, although we might use it. It's for Audit Wales. Well, who's commissioned it from Audit Wales? Indeed. So that's because there is obviously the whole piece around an EHCR case being worked up, which will be millions of pounds worth of investment. So, quite not unreasonably, they're going to want to have some information and baseline understanding of how likely that investment's going to land. Will it be deployed well, effectively? Because, there are examples, aren't there, in other parts of the UK where it's not gone so well. So, well, even in Wales, I mean, we've got some examples, haven't we? So I do. That was what was in my mind. I don't think we shouldn't engage with it. Let's use it, let's benefit from it. I think we just have to be mindful, that the information will be formulating some kind of information or plan.
Thank you. Okay, can I just look at the recommendation and perhaps consider the wording a little bit, David? Are we really being asked to approve the self-assessment, or have we been asked to approve the submission of the or sharing of the self-assessment with all of them?
To approve the lacking essentially of the board sharing this.
That makes more sense. Are you happy to do that, everybody? Thank you very much. Okay, thank you, David. We'll move on to 7.3, which is the Emergency Planning Response Resilience Annual Plan. Thank you.
Yeah, thank you. So, what I would just want to say about this is that I think we are definitely on the journey, and we're definitely on the journey of improvement. So, what I mean by that is when I first started in the organisation 3 years ago now, there were only 7 questions that we used to have to answer Welsh Government about our assurance around business continuity and major instruments at EPRR. We've now got 40. So we're definitely helping to influence with Welsh Government about what are the important things that we should be asking. So that's a good thing. I don't think we're quite there yet as an organisation in being able to be really clear about what our kind of worries are, what our risks are. So lots of these questions are yes, no answers. There's a bit of narrative. And yeah, we're definitely moving to make EPRR, emergency planning preparedness, more mainstream and what I mean, and to support the things that go wrong more often. So this is great for hopefully once in a career type major incident. But things like power going off and floods and buses crashing into bar park, I mean, these things happen at peaks. And that's the thing that we've tried to kind of get much more focused on is how do we get the business continuity side of things, how do we get more interest from the clinical boards, and so what I'm trying to say is that we are asking you to approve our return to Welsh Government, but I know there's a bit more work that we really need to do. But so let's pull out of these 40 questions that kind of work plan for our over the next while. So where do we think our highest areas of risk are, and what are we going to do about it? We did a bit about that. We set out some of the priorities, and we've used the NHS England framework to help influence that. So yeah, that's kind of what I wanted to say is that the cover paper it lacks a bit of detail. It gives a nice description, but it kind of lacks a little bit of detail to me that says of our 40 answers, this is what we're most concerned about. This is what we're going to do. So I suppose I'm just explaining on a bit of a journey. We're getting there, but we've got a bit more to do. In the meantime, we would, the ask of the board is to sign up our submissions so that we can.
Thank you all very much. Questions at all?
That I thought this was really good. I'll say. But partly, what struck me was some of the frequency of some of our failures. And I did wonder whether we might want to. It's appeared in here, but I wonder if there's anywhere else we should share this data or monitor this. Or I think you guys do it in tracking. Anyway, it was just something. Oh yeah, I remember that. Yeah, utility failure. So some of those things are the internet things, and then there's obviously the exercise that Claire referenced earlier, Pegasus, which is the National Pandemic Response Exercise, which will run. Is it a month or maybe I'm muddling?
It is. It's over.
So I think that, because I agree with you, I think this service is a kind of a requirement to submission. But actually, if we can turn it into more of an action plan for improvement and development, I think that would be really, really helpful. Because, like as you rightly said, hopefully this never happens to us. But those of us who've been in one of these when it really does, you'd be glad you've done all this homework if you need it. And the mandatory inquiry piece is there as well, and that's running down through the WASTA leading on that. So we need to make sure that that's tied in. Then just yesterday we got some new guidance on some other scary things, didn't we? And that flows in all the time as well. So it's quite a complicated beast, actually, isn't it?
Yeah, that's such a fun. So I wasn't being critical to them. I mean, it is good, but definitely on a journey. You can imagine 7 questions for an organisation of this size. We've got a tiny team, not making quite close to this. We've got 1.5 people. So the bit that's good around they are good at the training. They are these subject matter experts of all the things that we really hope will never happen to us. But we have also we're trying to stop the kind of acceptance of the power goes off and just get all the telecoms go down, which I think was happened last week. And that's probably why we don't report things as much as we've got used to things happening. So I'll take the action to link in with Jeff and thinking about it. Why don't we just produce a quarterly report or something just says the last 13 weeks, these things happen on some of the occasions.
Rachel?
Noting what you said, Paul, around the journey, I think it'd be really great about how we can assist with the training to broaden that small team. How can we bring it into some of perhaps our management courses? If they're out, let's weave it in. So maybe some what we could do together there as well.
I was just going to link it into the point that Suzanne made. You did say that this year strategically we noticed the outages, whether they were digital outages or whether they were infrastructure outages, and you talked about instance as well. I think we should categorise all of those, because actually that is something we do need to get downstream. I'm not sure we've got into collecting it, and you've got a quantum of information there, so you might be the answer to our. So I think there is definitely something for us to do together, so that we have a clear view of these things that take capacity in the moment, and actually a bit of foresight and a bit of work program linking in with the council. We could get downstream.
Okay, colleagues, are we happy to approve the response? Thank you, Lou. Thank you, Paul. Next item is 7.4, the committee annual reports. Matt?
Chair, this is the annual standing orders requirement for the committees to report firstly themselves, which they've done, and now into the report, which is asking for.
Nice and succinct. Anybody queries on the reports? Yeah.
Not a query, just a comment. I think the reports capture a huge scope of activity that's happening on the committee. And what reports of this nature don't do is capture how collaborative our committees, I think, are, and how well IMs in effect work together to sort of dig into issues. Particularly of all the committee chair, we've had a really, really good year in terms of getting into detail, getting assurance, but I just want to reflect, I suppose, on how collaborative everything's been in all the committees and the committees I sit on. The report doesn't necessarily capture that, but I think that's important.
Thank you, Ian. That's a really important observation. I think we're a collegiate board. I think the committee is very collegiate and put together. So, any other observations or questions? We're happy to approve the annual reports. Okay, let's go move on to the next item. Now, this is the into items for noting. The first one is declaring accommodation surplus. Contained in the recommended petition here, there are a number of approvals as well as voting. So I think it might be worthwhile you just position.
Apologies for getting it in. In terms of this, just to the stuff like being able to be able with that partners. On the east side of this estate, where the residential blocks are, there are 8 buildings, and there are various houses you can see in this document. Don't be 6 of the 8 of them. You're already empty. Year. That will give us, that will take the rate loading off the site. It will, which will help with some of the resilience issues. It'll also be better from a heat, light and power point of view, from a security point of view, and from resource sense for the future use of the building. Those buildings that I've mentioned there, Glamorgan and Monmouth are ready to be worked on this year. Carmarthen, Brecon and Denby have closed. The Sports and Social Club has been returned to us due to the Sports and Social Club not meeting with the charity and that accommodations come back to us. So the plan for that side of the site is to enhance our car parking facilities until such time as we have a plan we can and that may require an energy centre or something. We've then got where the Sports and Social Club is. We know that we've enhanced the disabled car park now. We've taken some COVID buildings away, the buildings that were there temporarily in COVID. We'd like to enhance the area in front of Lakeside to make it more of a bus and transport hub, to make it easier for patients who come to our sites to drop off and pick up if they don't have to be disabled or go under the underpass entrance in order to park their car. So we're looking to try and smarten up the front, and the Sports and Social Club facilities would be useful for that for all parties. On the other side of the site, there's plans afoot with colleagues in Cardiff Uni. The Tenebus building will be vacated this year, and that is a building that belongs to Cardiff Uni on land, and we are looking again to demolish that, to take the cost out of that, because obviously our colleagues building. There are also conversations happening about the dangers. We'll start to get a bit of the less. So here there are approvals to go to Welsh Government, to give you context of the UHB site, seek permission to prepare the accommodation surplus and to progress planning permission. Already so the funds to demolition of the site that is digitally.
Thanks, Captain. Very helpful. Mike.
Yeah, thanks very much, Chair. Your staff be happy about the next 2 places and saving the parking cars. So there's something good that can come out of this because wherever it goes. So are we clear? Are we sure when with our plans when we demolish these things? Contents of the things be not open to invest, or maybe part of the contract was take away or sell or strip, whatever. If so, with regards to the sports and social, can we deal with it? Is there any sporting equipment left there? If there is, can we have a cut-off as soon as possible to see who we do with that?
So the sports,
Unless they clean it all the way.
the issue is it went into liquidation, so all of the equipment didn't belong to us anyway, so we couldn't, it wouldn't be ours, so the liquidators will have cleared, managed the debts and given us back the buildings, so they don't have to. So, over and sleep. That's not our property. In terms of the buildings we've demolished since I've been here, they've generally been demolished for safety reasons. I'm thinking about the accommodation that Parkview Health Centre will go, and I'm thinking about the main building. We've had to take them down in emergency because they have and also security issues with people. So I think what we're trying to do is a bit more proactive. Your point about is there things in those buildings of value? Bearing in mind the state of the building, I'd say probably not, but it's a valid point, and we will need to check that out as we go. What we tend to find is patient records and other things that shouldn't be there, so they do need dealing with.
Very one last quick question from me. What I was looking at more than anything is the sports floors, squash courts, those rules of the standards on your way. A lot of money there. Unless, of course, as part of the contract becomes really keep on progress, but contents of something. For those floors, I don't know what condition that they did in make sure there's community-based projects within Cardiff and United projects. So we can look into it. We can look into it.
It belongs to us. And do that, then we do it.
Right, we can sell it. So do you think it's quite a question?
I can come in at the end.
And just to affirm Cardiff University's wish and willingness to collaborate on the estate rationalisation and to remain partners going forward into the planning of UHW2 if we ever get to that point. Some of us may not be ready by the end of this year. Feel that I might want to do some things in there that we might struggle to get rid of that we need to. What we'll do.
Get the planning permission, that one can go second.
Thank you. Obviously, the Sport and Social Club is a fantastic resource in terms of supporting the health and wellbeing of our staff and also the community that might live around the area. I just wondered if there'd been any thought given to getting a different supplier in or to re-provision of that type of activities later on. Thanks.
There definitely have been those conversations. During COVID, we provided a lot of money to the Sports and Social Club in order to use their sports facility storage, particularly over, of course, the time when that money was withdrawn. It was not a viable option. My understanding is the swimming pool did well, but the other facilities did not, and it wasn't viable and hasn't been viable for some long time. So, and anybody who was interested in bits of it. So that would give us a legacy problem. It's much easier for us to build it in going forward than it is to try and engineer it into that kind of thing.
Thank you. John?
I might just and take a visual, someone driving through Member, splash, maybe public, doing lots of that, and suddenly knocked down the marsh. It's communication to our community, to our population. I can't go into detail. I just wonder what's to be said. The local press, still not.
Yeah, I think it's a valid point, John. There's a communication plan around this and how we link it all together and what it looks like. There's active conversations with our neighbours on all sides. I think it's fair to say for a variety of reasons. But we will, particularly if it's on the east side, there's going to be a significant back. data to some of the buildings actually probably through the island. But I think it's fair to say that you're right. We need to first tell the people that use the site and the people who live around the site. As part of the kind of comprehensive plan in stages, which is why it's quite nice.
You're on the comms, did you?
Yeah, we've got a comprehensive plan that we work with Jeff's team on this, with the local councillors, the residents from Allens Bank Road, and all of the people associated with it that might just have an interest. So the RCN building as well on the end. So we've got all of that in train, and we also do it as part of the engagement with them as well to keep them updated. And what we've done previously, particularly when we've had a lot of lorries and, you know, the plant material and stuff, leaving dirt on the road and stuff, we always come up with a plan to work with them as well. So if they need to link in with us, but the engagement is always pretty strong around these things because we want to keep our neighbours on board.
Oh, I was going back to Claire's question actually. So I think, you know, it's been here a long time. So back in the 90s, it was a thriving business. Obviously, Claire, you're aware of the leisure facilities and students were on site. So it was that time. I think what's happened over the period of time is that the students not being on site, there's competitors around, you know, in the gyms, leisures, and now when we were looking at the benefits through discounts that staff can get through other gyms, modernised gyms, and so I think we felt there's enough around us and enough benefits that we're giving our staff around the wellbeing side of things. Yeah.
Well, this is a great news story. And I think we need a comms plan that says what a great news story this is. Those buildings are shocking, and we were putting people that are really valued members of our team there to live. And I personally was very pleased that we got a plan together. So I'm delighted. I think we can't knock them down soon enough. If we can generate what you're describing, Catherine, which is enhanced parking access, a different kind of, you know, because we don't even, I've got my new little working group with interested people. We've done a little kind of mapping to say you cannot walk right round UHW without having to walk on the road some of the time. There isn't even a pavement right round the site, which Catherine and I have discussed. So this will be an opportunity to kind of create safe pathways around the organisation, better parking. We can put in a kind of transport hub, maybe with a cycle access point, electric bike, you know, all that sort of stuff. You can do the what they are now. They're like swapping electric bikes. You don't have to buy one. You can just get to and fro from the station. I think this could be absolutely brilliant on that side of the site. So I'm very excited, and I'm fully expecting to get planning permission. And I'll say it here, hopefully that influence. And then on the other side of the site, I think we've got a great opportunity there to be bigger with yourself, Steve, around the dental hospital, obviously the site that sits behind the main HQ there, because that will join us together. You know, I think there's just, it will start to bring a modernity to the site that we just simply at the moment, you drive on the site and you think, oh, 1975, here we are, or before, and before. And I just think there's something about the impression that we want to give, you know, some of the technical delivery of care we do is so special, and we want to wrap it in a special wrapper, which we don't really have yet, do we? That gives the impression of professionalism, competence, 21st century. So I'm very excited to see this, as you can see, and let's wing it wherever it needs to go at top speed with a nice comms plan to kind of to celebrate this step forward.
Can I just change your limits to will go as fast as possible?
Exactly.
Okay, thank you, Susanna. Very enthusiastic. Well done. Any other comments? Okay, I hope you got your recommendations in front of you. This one, not going to read out the recommendation. I'm just going to ask you to approve for recommendation A that we note. Recommendation B that we approve. C we approve. D we approve. E we approve. F we approve. G we note, H we note, I we note. Being all content. Thank you very much. Thank you very much, Catherine. Okay, we are now in items of voting, so I'm just going to call the titles of it. Hopefully, you've had an opportunity to raise any issues with the authors of these reports before the meeting. So, corporate risk register, report from advisory groups, which is the Joint Commissioning Committee, committee and advisory group minutes, which includes people and culture, quality, finance and performance, local partnership forum. And we're moving on to items that we will discuss in the private section of the board today. That will include approval of the private board minutes, planning review, legal update, people and culture update, and approval of private committee minutes. Okay. Any other business from anybody? Review of the meeting. How was the meeting today, apart from being very warm? More content with the format? As always, please let me know if you've got any recommendations or help us improve or go in a different direction. That would be helpful. Next meeting will be convened on the 25th of September, which is a Thursday, here at Woodlands House in this same room. I now have to do a declaration of interest before we move into the private board. And that is to consider a resolution that representatives of the press and other members of the public be excluded from the remainder of this meeting having regard to the confidential nature of the business to be transacted. Publicity on which will be prejudicial to public interest, section 1, 2, public bodies, Admission to Meetings Act 1960. Thank you, colleagues. Thank you very much. Okay. Meeting closed. Those members of the public will now